Good morning, everyone, and thank you for joining us for the Medical Board of California quarterly board meeting. While this meeting is being conducted with all participating board members and staff in the Sacramento meeting location, this meeting is being streamed interactively using WebEx to allow for remote public comment in the same manner as recent meetings. Public comments will be heard for each agenda item for individuals wishing to comment in person and remotely. To be ready for remote public comment, we ask you please ensure that your comments can be heard clearly by connecting to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You'll see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you've joined the meeting with. By using this method, if you're having audio problems with your device, you will still be able to participate and hear the audio of the board meeting. Please see View Additional Meeting Information link on the first page of the meeting agenda for more information on connecting to the meeting and accessing meeting materials. Thank you, President Hawkins. You can now start the meeting.
Good morning. Good morning. Welcome to the Medical Board quarterly meeting and welcome to December. There's a change in today's agenda, item number 13. Mr. Lombardi has an unfortunate emergency situation and will have to reschedule to next quarterly meeting, the final report of the enforcement monitor. Thank you for your appreciation and acceptance of that change for circumstances beyond his control. I want to ask all of us to please turn your mobile devices to silent. You may notice board members accessing their laptops, phones, and other devices during the meeting. They're using the device to access board meeting materials that are in electronic format. If you're a member of the media and require assistance or information, please see Alexandra Shembra. Alexandra, please identify yourself. This is an official business meeting of the Medical Board of California, and disruption of the board's business will not be tolerated. Government Code Section 11126.5 allows the board to move people who willfully interrupt a meeting and to clear the room if order cannot be restored by removing or muting the disruptive people. We have a designated time on the agenda for public comment, and we'll ask for public comment on agenda items. The board welcomes public comment on any item on the agenda, and it's the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on the agenda item and you wish to speak on the item, please raise your hand or come forward and you'll be recognized. This meeting is also being streamed via WebEx. Member Mood is on WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host who will be facilitating the WebEx meeting. During each agenda item, the host moderating the WebEx will activate the hand raising and Q&A feature of WebEx. Only ask anyone wishing to make a public comment to indicate so by raising their hand or entering yes in the Q&A window. The host will then call on individuals who indicate they wish to make public comment by name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual. They'll have 3 minutes to make the public comment. But this time period may be reduced depending on the number of people who wish to speak so that more people may be heard. The host will automatically announce when 30 seconds remain to conclude the public comment. After 3 minutes have elapsed, individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. I want to remind all speakers to please stay on topic and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law. We plan to end at or by 3 p.m. I would like to call the meeting to order. Ms. Moriarty, please call the roll.
Dr. Bolot? Here. Mr. Brooks?
Here.
Dr. Hilzer? Ms. Jong? Ms. Lawson?
Here.
Mr. Lee? Ms. Lubiano? Dr. Mahmood?
Yes.
Dr. Thorpe? Dr. Sai?
Here.
Mr. Watkins?
Yeah.
Dr. Hawkins?
Here. We have a quorum. I'd like to remind the members again that we will take a roll call vote on all action items. Moving to agenda item 11, presentation of findings from the mandatory licensure renewal survey. Ms. Kaufman, welcome.
Okay, well, we've already established that I'm not the most tech savvy, but, and so it's a good thing I've got Sean here to help with the slides. So thank you very much, Dr. Hawkins and the board. Really happy to be with you here today and share some of the work that our team at Health Force Center at UCSF has done in analyzing data from the board's mandatory surveys. So just by brief background, I'm on the faculty at University of California, San Francisco, and I've done really work on the health workforce, including the physician workforce, for probably about over 25 years. And our Health Force Center at UCSF is really the locus for all of the work we do at UCSF on health professions, include, the full range from physicians to nurses, dentists, pharmacists, also look at folks like community health workers, medical assistants. Sean, should I wait till you get the screen queued up? Okay. Okay. Shall I go ahead, Dr. Hawkins?
Yes.
Okay. All right.
you.
Okay, so Sean, if you could go to the second slide. So just some background here. The medical board, I think as many of you know, has conducted surveys of physicians as part of the licensure renewal process from about the mid-2000s, and that was mandated by the state legislature. And so our team, we've been really fortunate and really greatly appreciate the partnership with the medical board, where we've analyzed and go about the past 15 years or so, different waves of the mandatory survey. We also did a few supplemental surveys with you looking at electronic health record use and participation in the Medi-Cal program. Really value this partnership. I'm going to talk about findings that were released in 2021. We typically release our findings as part of what are called the Physician Almanac series published by the California Healthcare Foundation. So it's a series of chart books. So I'm going to talk about those 2021 findings. We're in the process, just getting started on analyzing 2023 data and expect to release that at some point in 2024. And so I'm happy, if it's of use to you, to come back sometime late next year and talk about that. So let's go to the next slide, please. I'm going to first talk about some findings about supply and distribution. Next slide. And so here we're going to talk, this slide I put up to really make the point that when we think about the supply of physicians, we need to be really clear about which physicians we're talking about. That if you look at your data from 2020, there are about 152,000 folks who have a California MD license. But if you then say, well, what I really want to know about are those physicians who are providing patient care, who are taking care of people in California who need medical care, well, then you need to go over to the right-hand side of the slide. And if you want to, you see that we have about 75,000 that provide patient care 20 or more hours per week. And that's sort of a standard definition of an active patient care physician. And then we've got about another 12,600 who provide patient care less than 20 hours per week. So, I mean, those are people who are choosing to work part-time. Also, probably a fair number of academic physicians in there. As those of you who are academics know, pretty common for academic physicians to maybe be in clinic one afternoon a week and rotate through the hospital 2-3 times a year. So they're not doing that much. They're important work. And a lot of that important work is training residents and medical students, but they're not providing a lot of care. So I think that's really important. You've got quite a few, as you see there, a number of folks who are practicing out of state. And again, maybe providing really important services, but they're providing them to somebody in Colorado, Arizona. They're not here in California. So we tend not to look at them. We also tend to not look at the residents and fellows because of the way we really can say who's completed all of their training and is out there serving the public. And then we base our estimates on the responses to the survey. So you will see there's some folks who don't respond to the mandatory survey or for whatever reason choose not to answer the patient care hours. So this is probably a conservative estimate of how many we're providing patient care. Sean, let's go to the next slide. And this is just to show you a little bit of trend over time between 2015 and 2020. And we see there we've had a growth, I'd say modest growth in the numbers of physicians providing patient care. We've had about 1,000 increase in the number of MDs providing patient care less than 20 hours per week, and about a 4,000 increase in those providing it 20 more hours per week. So I think some good news on the supply side, but still pretty modest growth. And we're really looking forward to taking a look at the 2023 data and see what's happened since then, given the pandemic and everything we know we've all been struggling with. Next slide. And so this slide sort of takes hours of patient care per week and breaks it down into deciles. And this is consistent with the way the question is asked on the mandatory survey. And I'm guessing some of you here who are in the room or on the board as physicians, you're familiar with this because you probably had to fill it out yourself. And we certainly hope you filled it out. Your data. So I think 44% here provide patient care 40 or more hours per week. You know, and 40 is what we often think of as full-time. And then about another 34% providing it, you know, somewhere between 20 and 39 hours per week. Now, keep in mind, this is just patient care hours. I mean, many of our physicians are also putting in substantial hours of administrative time for, you know, documentation and whatnot. So those who are working 40 plus hours per week probably want to add maybe another 5, at least 5, maybe 10. Dr. I'd say maybe at least 10 hours of additional week work spent on that. But still think important that there's a sizable chunk of our physician workforce that's not quite working anywhere close to full time. And we'll talk about some reasons why that might be in a bit. I want to turn now to specialty distribution. Sean, next slide. So this slide, what we did is use the data from the mandatory survey about physicians' primary and secondary specialties to identify the 10 largest specialties in California. And you'll see the number one up there is internal medicine. So this is general internists. People, based on their responses to the survey, indicate that their primary specialty is internal medicine and don't report having any subspecialties. Then the second largest being family medicine and the third pediatrics, and you can see the others there. So you might look at this and say, okay, we're doing pretty well on primary care if internal medicine and family and peds are our largest specialties. I think if we go to the next slide, we'll see that we want to, you know, be a little cautious about that conclusion. So what we have here are ratios of primary care and specialist physicians per 100,000 population. California overall is in the green at the bottom, and then the regional estimates are in sort of the rust and gold colors. And we do this per 100,000 population so that we have every region of the state on a same basis. I mean, if we know California, this is really important for us in California. You know, we know, for example, Los Angeles County, you know, has more people than many states, more people than many countries. It is a very big place. If you just compare raw numbers of docs in Los Angeles County to what we call the Northern and Sierra region, which is the rural counties north of Sacramento, wrapped around the spine of the Eastern Sierra, you've got tons more docs in Los Angeles County than in that really large geographic region. And in one level, that's important to know, but if you really want to make comparisons, you've got to standardize them. And so that's why we use a per 100,000 ratio to do that. And so we see in California overall, we've got about 60 primary care docs per 100,000 population and about 131 specialists. And the way we define primary care is general internal medicine, family medicine, pediatrics, general practice. There's still a few folks out there that are general practice. And then we include obstetrics, gynecology, which, you know, not everyone I think reasonably would agree with. We've done that because if you may remember back in the late 90s, early aughts, you know, women were given them, you know, under our laws around managed care that women could self-refer to OB-GYN. And certainly there are OB-GYNs who see themselves as primary care providers. So we've done it that way, but understandable that not everybody would. And so what we see here is looking across the regions is we've got this really, very big, we have twice the number of primary care docs per 100,000 population in the greater Bay Area than in the Inland Empire, being San Bernardino and Riverside. So that's a big gap. When we look at the specialty side, it's even larger, 173 per 100,000 in the Bay and 81 per 100,000 in the San Joaquin Valley as the lowest. And as you'll see there, the Inland Empire and the San Joaquin Valley lowest, and then followed by the Northern and Sierra. And sadly, if we were to turn back time to 20 years ago, pattern would be about the same. Some of the point estimates have changed, but the pattern is pretty much the same. We have persistent inequities in distribution of physicians across the state. And it tracks, I think, unfortunately, pretty well with differences in rates of poverty and economic well-being across the state. Next slide, please. And this is just to unpack that a little further. This map is showing you ratios of primary care physicians per 100,000 population in county level. So the light turquoise are the counties with the lowest supply per 100,000 population, and the dark blue are the highest. And so this is, I think, consistent with what we see on the regional data. We see a lot of light turquoise up north of Sacramento, down through the light turquoise and dark turquoise in the Central Valley, Inland Empire, and then Imperial County, which interestingly doesn't show up so well in the regions because regionally we've combined it with San Diego because of, I think, particularly for specialty care, the nexus there. But what you see is Imperial County looks a lot like some of those other agricultural counties that are in the valley, Central Valley part of the state. So really, I think, important challenges for us ongoing in California about how we provide access to physicians in these rural and agricultural parts of the state. Next slide. Going to now turn a bit to talk about demographic characteristics of physicians. And next slide. I'm going to start with looking at where people complete their medical education. I mean, this is a question I'm often asked a lot about. And so I think what we did here is there's data that the medical board collects at the time physicians apply for licensure on where they did their medical school. Understandably, appropriately, you want to know that they've graduated from an accredited medical school. And so what we have here in gray are the proportion of docs who graduated from a California medical school. So that could be University of California, could be a private school. The rust color is sort of other states, and the blue is international medical graduates. And so you'll see we really only have a little, somewhere between 20 and 25%, about a fifth to a fourth of our physicians were educated here in California. We have quite a few who are educated in other states. Now, some of them are Californians. Some of them are people who are born and raised in California, but go out of state for medical school. I mean, we have one of the lowest ratios of seats in medical schools to folks applying to medical school in the country. Now, we've added a number of medical schools in recent years, but we're still pretty much on the low end. So I think it's no surprise to anybody that we export a whole lot of medical students. I think what's also important to note, there's about 28% of our MDs were educated outside of the United States. And then when we disaggregate primary care physicians and specialist physicians, we see that we have a much higher proportion of international graduates in primary care. Next slide, please. And so this is looking at the age distribution of physicians. I mean, it's no secret to any of us that the baby boom generation is reaching, not even reaching, is at retirement. Many is at retirement age now. And that certainly, I think, is affecting what we see in physician supply. I think, interestingly here, in 2020, a full 19% of physicians who were active patient care, said, I'm doing patient care 20 or more hours a week, 19% were age 65 or older. So I think it's certainly possible that some of those docs are retired today, or certainly are going to retire, in the next 5-10 years, or at the very least cut back their hours. So I think we want to continue to monitor the age distribution, really look at the entry of new physicians to replace those who are retiring. Next slide. So people often ask me, well, you've been at this for 25 some years, what's changed and what hasn't changed? Well, one of the things I think that has changed in medicine is our gender distribution. And I put this slide up to just give us a little data point on that. So in 2020 in California, about 22% of our physicians were women, 78% men. If we look at 2020, we go up to 38% women. And I think this is, certainly a reflection of the fact that when we look at who's graduating from medical school today, it's pretty close to 50-50. That looks quite different than it did certainly in the 70s and even the 80s. So I think that's a point of progress for, women who prefer to have a women physician. Let's see, let's go to our next slide. And here's the slide where I say the thing that, hasn't changed and where we still have a lot of work to do. Now, this is just a 2020 snapshot. We've got the racial ethnic distribution of the California population on the left, and this is from the census. And then we've got the racial ethnic composition of physicians on the right. Now, before I talk about the gaps, I also want to talk about first the data gap. You'll notice that kind of magenta color. 18% of physicians do not answer the race ethnicity question, decline to state. They check a box that says decline to state my race ethnicity. We have another 5% who just skip the question. So we have to understand that there's like quite a few physicians where when we look at the mandatory survey data, we really just don't know what their race ethnicity is. But when we look at those who we do know, what we see is we see some gaps for Black Californians. 5% of California's population is Black. 3% of our physicians are Black. And we see what I would argue is not just a gap, but a chasm for Latino Californians. 39% of our population is Latino. I mean, that's certainly something that has grown over the years, but only 6% of our physicians are Latino. And that really hasn't changed much over the past 25 years. And despite some really concerted efforts on the parts of many folks to address that. And I know we're going to hear about one of those efforts a little later today. So that, I think, ethnic diversity remains a challenge for us. Let's go to our next slide and look at linguistic diversity. So this slide, we use data from the mandatory survey on the languages that MDs speak. Now, I will caution you, this is self-reported data. So we have, if someone says, I speak Spanish, we're taking them for their word. We don't have any way of validating whether they speak Spanish well enough to provide patient care without an interpreter. But anyway, the 5 languages that I've chosen here are the 5 languages that are most frequently spoken by the population of California other than English. Spanish is number 1 by far, but then the 4 most common Asian languages are Chinese, Tagalog, Vietnamese, and Korean. So we see that about 26% of our physicians say they speak Spanish. I hope all of them speak it well enough to provide patient care. If they do, that's, I think, encouraging news. While it would be, I think, ideal for our Latinx Californians to have physicians who both speak the language and understand the culture, even just speaking the language is something. But I look at the Asian languages, and I do think we have some gaps there. Even though we have a lot of Asian Pacific Islander physicians, the race ethnicities may not match. And even if they do, if someone is, say, 3rd generation Asian American, their ability to converse and provide patient care in those languages is not necessarily always, strong there. And so I think we really, as much as I think on ethnic diversity, we really need to focus on Latinos and Latinas. I think in linguistic diversity, we also need to take a hard look on language access for our Asian and Pacific Islander Californians. And certainly we need, to continue to pay attention to access for our Black and Native American Californians. Language may be less of not an issue there, but certainly issues of access and trust are big issues that we need to continue to work on. Next slide. So when I talk about what I call the new HCI questions, or actually I think, Sean, you called them the new HCI questions first. So let's go ahead here. Next slide. So in 2021, the state legislature and the governor established the California Health Workforce Research and Data Center. And this is housed at HCI, the Department of Healthcare Access and Information, what used to be OSHPD for us old timers. And the purpose of this center is to provide a central source of data on health workforce and education, to really be the go-to one-stop shop in California for this data. And it partners with all of the healing arts boards to collect survey data via licensure renewal surveys. Now, prior to this legislation, you and the medical board were collecting data for many years. Nursing was collecting similar data, but doing it through a sample survey. And there've been some efforts, but this is, I think, really a big step forward to say, we're going to get all the Hailing Arts boards to collect these data, and you're all going to try to collect it in as standardized a way as possible through licensure renewal, so we can really make meaningful comparisons across professions. In the context of the medical board, what I think is important here is being able to look at MDs and DOs and have the same data on both, and also to look at nurse practitioners and physician assistants, where we know there's a fair amount of overlap in scope of practice. And we certainly know that there are many physician practices across the state where NPs and PAs are part of the care team. So I'm excited about that. Let's go to the next slide and talk about some of the new topics, because it's not just collecting the kind of data I've just shown you. There's some new topics here that I think are important. One is practice setting. Prior to this time, we really haven't had great data on practice setting. We did that through a couple of our voluntary surveys. I'm not convinced we got the categories right, but we tried. But at least now we're going to have some practice setting to be able to say, well, what fraction of our MDs work at Kaiser? What fraction are in other private practices? What fraction are in our safety net types of practices? We're going to learn more about where people are practicing. We're going to learn about employment status. We've inferred that from the data on hours worked, but it'll be nice to have a question that really asks, are you working? Are you not working? That asks about your retirement plans. What are you planning to do? That asks about your residency location. I showed you the data on medical school location, and that's really important. But residency location is very important too. National studies have really shown that residency location is the stronger predictor of where you're going to practice. We've looked at those data from sort of national sources, and they tell us that California does a really good job of retaining our residents. We're #1 in the country for both medical school and residency. But what they don't tell us is, do our residents that train in our underserved areas, to what extent do they stay there? Because I think one of the things we want to know as the HCAI knows that we've invested in residency programs in places like Ukiah, in places like Eureka, starting out new psychiatry program in Butte County this coming year. We really want to know, do those folks stay in those parts of the state where they're most needed? And so I think that's going to be exciting. We're also going to learn some stuff about gender identity and sexual orientation. Next slide. And so just really conclusions to wrap up, because I'm probably low on time. Next slide, Sean. So, we've seen some modest growth in the number of MDs over the period from 2015 to 2020. We continue to have substantial geographic maldistribution with low ratios of primary care physicians per capita in many parts of the state, and low ratios of specialists as well. Large share of MDs near retirement age, and racial, ethnic, and linguistic diversity that doesn't reflect the diversity of California's population, and some new survey questions that I think are going to yield additional insights. Next slide. So I just thank you all in the medical board for your support in doing this work. I want to thank the California Healthcare Foundation that's funded a lot of this work, and acknowledge my collaborator, Margaret Fix, one of our research analysts who's been my partner in doing all this work.
Well, thank you very much, Dr. Kaufman, and thanks for returning. You've been here before, and we look forward to having you coming back again with that new data, particularly HCI and the 2023 data.
Mhm.
So self-reporting, I'm a physician in private practice. I'm an internist and a pulmonologist, but practice predominantly general medicine at this stage. I'm in that latter group,
Mhm.
but are still practicing,
Mhm.
that over 65 group, is still practicing. There are a lot of questions to ask, a lot of food for thought. And I want to ask you about, the Philly Quality Health Centers actually provide a lot of care for Medi-Cal
Mhm.
patients, and there are individual folks in practice too. So one question is, what's that distribution look like? And the other is, how are we doing, if you know, with the incentives for physicians to practice in underserved areas, given the cost of medicine? So we know that there are a number of programs that
Mhm.
incentivize physicians to practice in those underserved areas with loan forgiveness. How are we doing there? And what about the information about who's providing the care to these Medi-Cal citizens?
So a couple questions. I'll answer the first question. And I think the first question is, one of the things that's exciting about this data is that I think that will help us tease that out. I mean, right now we can look at, from the mandatory survey, we can look at zip codes and we can say, well, is this a doctor practicing in a zip code that's in a health professional shortage area? for physician, either for primary care physicians or psychiatrists. So we can look at that, but we don't know what type of practice they're in. And so I think the new data will help us say, well, of those docs that are, say, in South Central Los Angeles or in rural towns in the Central Valley, how many of those are in a public hospital, community health center setting versus in a private practice? So it's a really important question. Now, on loan repayment, we actually, I think the good news in California is over the last 10 years, we've substantially increased the amount of money that we put into loan repayment. Some of that comes through programs that HCI administers, like the Stephen M. Thompson program, for example. There's also the new fairly new Cal Health Cares administered by Physicians for Healthy California. And they both relate to underserved areas. The Stephen M. Thompson National Health Service Corps, a little more geographic location focused underserved area, whereas Cal Healthcare focuses more on just what's your proportion of Medi-Cal patients. And so those are there. So I think we're doing more. Are we exactly where we need to be? No, probably not. And I think one of the things, and I know at least that folks are interested in this, is better understanding the outcomes of those loan repayment programs. We've still got work to do to understand how many of those folks stay in those underserved communities after they complete their obligated service, and not only stay in those communities, but stay in a setting in those communities in which they're caring for folks who are on Medi-Cal or uninsured. Great question.
Yeah, thank you very much. So last comment before opening up to the board and the public, information about medical students and physicians in training, staying in an area where they get their training, either medical school education or their residency training is really, really important. We do have a new medical school in the state of California, Charles River University.
Right.
And it's very interesting looking at the diversity in terms of the students they've admitted.
Mhm.
That speaks to some of those underserved
Mhm, mhm.
populations groups, African American, Hispanics. So this is very good information, important information. Are there questions from the board?
Yeah. Dr. Kaufman, thank you very much for your brilliant work, and it's always important. I often pull those slides up when I'm talking to new applicants and really thanking them for going into primary care in the first place. It's a lot of hard work. My question is, when you think about the programs for increasing PAs and Ps, and you think of that 19% of the doctors that are at 65 and near retirement, what's the delta? Where's going to be the gap as we start to kind of change when doctors are leaving? So the input is the doctors coming in,
Mhm.
supplemented by NPs, PAs, extenders, right?
Mhm, mhm.
Do you have a sense of that, what's going to happen? Because right now, access for
Mhm.
medical care, healthcare is really woefully.
So I think
Or-
those are good questions. We have a forthcoming project next year that I think is going to help us answer that better. But what I will say, we have seen substantial growth particularly in nurse practitioners, and also in PAs, but you start from a much smaller base. And so I wish I had the graph that I've shown in the past that shows you sort of numbers of MDs, then DOs, NPs and PAs, and just the number of MDs is so much larger that even when we have, 60, 70, 80% growth in NPs, we still don't have, we're still not at replacement. That's why I think important watching this expansion of medical schools. Charles Drew, is a great example. We have the new Kaiser Medical School. We have some others that have opened, and tracking to see what's happened there, I think will be important. Also tracking what's happened with our residency programs. But yeah, I think if anybody thinks that we can solve our physician access program problem by just relying on NPs and PAs, the numbers just aren't there. And I think in primary care, what's also important is if we look at NPs and PAs, we cannot assume that they will all go into primary care. They don't. In fact, about 50% of the PAs go into specialty care, and increasingly some of the NPs do as well.
Thank you, Dr. Kaufman.
Yes, Dr. Heiser. Microphone.
Good morning, and thank you for your presentation. Are you also collecting data on osteopathic physicians, and do you see any interesting differences between the two groups, MDs and DOs?
So great question. We've primarily partnered with you here at the medical board to analyze your data on MDs. With the new Health Workforce Research Data Center, there will be data forthcoming on osteopathy. So we've looked at osteopathic physicians to the extent we can. I mean, we can certainly pull down the publicly available data from the osteopathic board and say, well, here's the number, and we've got zip codes of preferred address, which may or may not be a practice address. So we've done some work to map that out, but this is a place where I'm excited about the additional data available to understand osteopaths better. I mean, I think what we can say is that we are a state where the number of osteopaths is substantially smaller than the number of MDs. That's not true across the country, but it is true of us. What we have seen is that in our more rural parts of the state, we tend to see somewhat more osteopathic physicians relative to more DOs relative to MDs. One of the things I really think we want to look at, again, with DOs too, is what's the specialty distribution. I mean, historically, they've been, concentrated in primary care, but they are also going into specialists. I mean, we have one of our neurosurgeons, very talented, very gifted primary care person, got his DO from Toro. So I think that's, again, just to say that we need to unpack what the data does is enables us to really unpack and not just make reflexive assumptions about who's doing primary care and who's not.
Yes, Mr. Brooks.
Thank you very much for your presentation. Absolutely fascinating. As I'm, looking at or recalling some of the slides that you put up, mainly when you're looking at the gap of the population of Latinos to the population of Latino physicians, or the gap between doctors in rural areas versus, the metropolitan central areas. What is your recommendation to fix it? I mean, if we could create legislation today, or we could have some new guidelines today to encourage more Latinos to get into the profession, what would those recommendations look like? How do we encourage more people to get to those rural areas? And the second part of the question is it a barrier for access? Is it a cost issue? I mean, what's the driving factor behind, the stats that you put up on the screen today?
A really good question. So let me break it down. I mean, I think, one part is, continue to do some of the things we're already doing around, particularly around rural, and that's loan repayment and scholarships, and that's, residency programs in rural areas. I mean, I want us to learn more about how effective those are, but I think there is some evidence already that they are effective. Certainly evidence nationally that rural tracks and rural residency programs do produce more rural physicians. So I think that's important, but I think I want to elaborate more on getting more Latinos into the professions. And I think it's complicated, but some of it boils down to structural racism, just as it does for Black Californians and Native Americans. Many of our Latinos, Black and Native American Californians grow up in low-income communities. Their parents have not had great opportunities, so their parents don't have, if you will, the social capital that, say, a child of a physician or even a child of a lawyer or even children of school teachers have in terms of the importance of education, getting getting as strong of an education as you have and knowing how to navigate that system. Knowing why, if your child aspires to be a physician, why you might want to really see if you can get them into a UC instead of a community college, wanting to really being able, and some of it's wanting and some of it's just ability. Our low income families, I mean, we have a state with some of the high, even though we have some of the highest wages in the country, we also have some of the highest housing costs. And so many of our low income families have to rely on their children to be part of the economic support for the family. And so if you're in a situation where you need your kids to help put food on the table and pay the rent, it is hard for you to be the parent who says, I'm going to make sure that you have time to study. Instead, you're often the parent saying, hey, can you watch the little, can you pick the little ones up from school and watch them while I'm working? Or can you contribute X amount to the rent? I mean, so that's, I think, one of the roots of it. But then I think we get to, we get folks, we do, despite that, we have many folks who are Latino and I think that's one of our success stories in California. Is we have many more Latinos graduating from college, and we certainly have Black and Native Americans graduating as well. But they get to college, and if they haven't been fortunate enough to have a really strong foundation K to 12, they get to college and struggle. And for medicine, what matters the most is that they get into chemistry, other high sciences, but especially chemistry. They get in there and they really struggle often. And unless they're fortunate enough to go to one of our campuses like UC Berkeley that has something called the Biology Scholars Program, where there is a program that really says, we believe you can do this. And we as faculty and staff are going to support you. We have a network of peer mentors, folks who've taken this class and who are going to help you. Where do you have that? I think people make more success, but a lot of our campuses, we don't have that. And so you take chemistry, Chem 1A at Berkeley, you take Chem 1A, you take a class like that, you don't have a lot of resources. Your teaching assistants are chemistry or biology, physics PhDs who they're in the PhD program because they got this stuff fairly easily and are good at it. So you don't have that support. And so they get discouraged. And unless they've got good mentors, they may say, well, I can't do this. I can't, this isn't for me. I need to look for some other major. Now, some of those folks go on and are in nursing or in public health, and they do really good things in health. But that is a big barrier, I think, for medicine, is that it's first getting to undergraduate, and then in undergraduate, staying on the track. And then a third thing, which I'm sure will get me in trouble with some people at UCSF, but I'm going to say it anyway, is when we do medical school admissions, we tend to have sometimes some pretty narrow ideas about who's going to be a successful physician. And I think I think at our very best, I think UC Davis and I think we do at UCSF increasingly, at our very best, we are more thoughtful. We look at the distance traveled. We look at as somebody coming from a community that's underrepresented in medicine. At our very best, I think we do that. But I think if we're honest, we still come to that with a bias that an Ivy League school is the best, UC is good, and well, Cal State, I don't know. I know that's a long-winded answer, but I think I make it a long-winded answer because I think it is complicated.
Yeah, thank you for that complexity. Touch on a number of issues. Dr. Sai.
Thank you for your presentation. I always like to see the results of the surveys I fill out. I think I wholeheartedly agree with you on how California med school admissions is structured to attract the very best from around the country. I grew up in the Bay Area. I went to undergrad at UCLA, but I went to med school in Southern Illinois. And Southern Illinois is a medical school that their mission is to train the future physicians for the downstate Southern Illinois. And so class of 72, except for us combined degree candidates from out of state, everybody was from within about 100 miles of the area. So when we graduated, they all found residencies in the area. When they graduated residencies, they went back to their towns. So this is where they grew up. This is where their families are, their cousins are. And I think for California, our med school, I'm faculty at UCLA. We get residence med students from around the country because they're excellent. They're stellar. They're the top of their class. So it's very interesting to see, how UC Riverside's going to do and how Drew's going to do. And these medical school now gearing towards that area and see what their graduation or graduates will do. So I think it's a very, very useful statistics for us because, practicing in the community, there's not enough specialists because, even in LA where we have the most specialists per capita, when we have to refer to somebody, now specialist waits pulmonologist 3 months. I mean, how can you wait 3 months if you need specialty care? And so I'm really, really interested and will be interested to see how the follow-up surveys do.
Right. So just to, thank you for your comments. I think I should mention that, each of the UC medical schools does have its prime programs, for care for the underserved. And there are, rural prime programs in the Central Valley. And so I think we do have some and so the prime programs are really sort of a cohort of medical students who are committed to serving a particular underserved population, either geographically or racial, ethnically based. So I think we do have those, and they are really important, but they're relatively small. When you look at the total number of medical students, the prime students are small numbers. You do have programs like Compadre at UC Davis that are partnering with rural. So I think I want to be careful and say it's not that, I mean, I think we are doing some things that look like Southern Illinois, but not on the same scale. And so I think that's our challenge is how can we scale up what works in terms of educating and preparing people who are committed and interested in serving an underserved population, practicing in an underserved area.
Excellent, great. Mr. Watkins, and followed by Ms. Lubiana, and then perhaps we'll
Yes.
go to the room.
I just want to say thank you. This has been a pretty amazing conversation to have. And when you threw caution to the wind, I thought I'll throw out something out there as well. We have the Mexico pilot program. We're going to look at that. And that is a useful program for, addressing some of the issues. But I'm going to bring a little bit of experience into the space because back in the early 2000s, I was in the University of Cape Town Medical School. I was doing another project there. And we imported a whole lot of primary care physicians out of Cuba. They only spoke English and Spanish. And I know the Spanish that they speak in Cuba is slightly different than the Spanish that are spoken here. What do you think about, exploring, because that divide that Mr. Brooks spoke about, it's jarring about, expanding Mexico into Cuba because they have I think they've got the biggest per capita doctor population in the world. I was just curious, as a professional, what would that look like if that is even viable?
Well, I think that let's take the politics of Cuba off the table because I
Yes,
think that's
yes,
above
yeah.
the pay grade of everybody in this room. But I think certainly, we're going to hear from Dr. Aguilar about the Mexico pilot. So I think that's really important information. And I think it's worth exploring and asking the question about other Latin American countries. I think the only comment I would make is if we look at our Latino population here in California, that population is primarily of Mexican and Central American heritage. So I think if we were to import physicians from Cuba, there would just be some things to think about because language is clearly important, but culture also matters.
I want to make sure I don't ignore Dr. Mahmood, who's actually virtual. Just want to make sure, Dr. Mahmood, did you want to make a comment? You don't have to, just want to make sure.
Yes, I was raising hand. Thank you so much. This is such an amazing presentation. And it's really sad to know that only 6 or 7% of our doctors in California is Latino, and they are the biggest in the biggest need for healthcare. I just want to extend this thing from Mexico pilot program, and TJ mentioned about Cuba, but I was trained in South in Kentucky, University of Kentucky, and I have spent quite a time in Midwest and South, and they have really utilized people from South Asia, Indians and Pakistani doctors. You go to any small town in any Midwest and South cities, you will find definitely half the population of doctors in any specialty will be South Asian, either Indian or Pakistani. And at least there is not a problem at all about English. Obviously, Spanish will be. Would there be any way to attract those doctors to come to California and put a restriction on them to learn Spanish if they want to practice? And there are so many physician deficient areas, especially Central Valley and up north further above Sacramento, where we can adjust them. And even after LA, go to East Riverside and San Bernardino County rural areas, there's a whole lot of need. And we come up with something innovative because I'm not being in a bias because I'm South Asian, but I tell you that work ethics and hard work and their knowledge has proven time and again that they're the second biggest physician population in this country, actually, after Caucasian. We should do something really practically to attract them and bring them over here. And on top of that, as everybody has mentioned, create some more incentives for Californians to go to medical school or have some special quota or something who pledge to stay in California, because California really needs a lot more doctors. Thank you.
Mhm. So several things there. I think, we didn't present that data, but yes, I think in rural communities in California, our South Asian physicians are a big part of the physician workforce there. They are, that if we look at where our international physicians are coming from, South Asia is the predominant place. I think, I think it's sort of a policy question about whether anybody would be required to learn Spanish, but certainly perhaps I think more could be done, say, to provide resources to help people learn Spanish. I mean, we have some examples like the Train the Trainer programs for primary care psychiatry and primary care addiction medicine. Maybe we need something like that to incentivize intensive medical Spanish for not just our South Asian physicians, but for all our physicians. And then in terms of medical school, I think again, that's a policy. I think what Dr. Sai was saying is that, and my guess is in Southern Illinois, part of the reason you had so many people from Southern Illinois in your medical school is that was when the admissions committee looked at applicants, that's something that they were thinking about and taking into consideration. And we do that in our medical schools to some extent in California, but not, I would say, to the same extent as some places like Southern Illinois, with some exceptions. Drew is a big exception of really looking and being very thoughtful about admitting students who want to serve underserved communities. But that's not sort of the criterion we use to select the majority of our medical students. And I should say, it's not that Californians don't want to go to medical school. We have plenty of applicants to medical school. We, export, it used to be, we export about 10, the equivalent of about the average of 10 other medical schools. So we have plenty of Californians who want to go to medical school. I think it's, really focusing on in California, how do we admit the folks who have a passion to care for the underserved? And then how do we get more of our Californians who are Latinx, Black, American, really to the place where they can be competitive applicants and obtain admission?
That last comment speaks to the pipeline issues that you have to start really, really early. Ms. Lubiana, before we go to the room.
Yes, thank you. That's a good segue because my comment is about pipeline. And thanks again. I love numbers and graphics to demonstrate the message. And so as you were speaking, it made me think of the pipeline issue for girls and BIPOC communities and other diverse communities. So are you aware of active efforts to attack that issue? Introducing kids as young as middle school or high school to help increase that pipeline?
So I think they're certainly out there. I mean, one really good example is the Doctors Academy in Fresno that was founded by Dr. Catherine Flores. And so they started really at the high school level, started at one high school in the southern part, we're underserved, really racially, ethnically diverse, low income part of Fresno at one high school, really working with students at the high school level to help them be as prepared academically as they could be for college, helping them get into college, and then partnering with the local community college and especially with CSU Fresno to support these young folks in getting their college education. They've since grown from that one high school to multiple high schools and to middle school programs. And I think what's important there is not only the pipeline, but one of the things Dr. Flores says, it's how it's so important to get the parents involved and not just the kids, so that the parents understand, what it takes for their students to become physicians and for helping them to be more supportive of their learners. But having said that, you don't have a doctor's academy in every community across the state. You can point, I think UCLA, you all are doing some things. I know we're doing some things at UCF. There are things, but it's not uniform to have something that intentional with that many resources. And I think you mentioned girls. I think one of the things we have to say, particularly in our Black community, is that we have an even bigger challenge of getting Black men into medicine than Black women. It is not easy. It is not a proportion of Black women, but when you look at the gender distribution, there are more Black women going into medical school, going into any health profession than Black men. And I think we need to call that out.
Yeah, thanks for that. Sorry, are you saying something else?
Oh, I just said thank you.
Oh, yeah. And so before we go to the room, I think that touching on a number of very, very important parts of this puzzle speaking to the complexity of it. And I think that when you talk about pipeline issues, there are medical societies, there are national societies, there's individuals that go into schools, grammar schools. So we all have to think about what way can we be part of that solution?
Mhm,
How can we give back to actually be a mentor, to share our experiences, to let folks know you can do what I've done. And thanks for your patience and being with. We do have a little more time. So comments from those in the room before we go to the WebEx? Yes, please come up to the mic.
Everyone, and thank you for this meeting. And you have to forgive me because by me being in ministry, I talk loud anyway. So I'm not at the mic. As far as Illinois goes, I grew up in Illinois, and at one point they had made it to where we couldn't have music classes. And so my mother sent her to Costa Rica to be inundated for one summer, and she came back and she was able to teach Spanish classes. Now, something might be looked at. There may be some programs that could be set up where the doctors could be able to learn to become bilingual. That's one thing. Something else that you might notice, who gets into schools often has to do with the grade point averages coming out of high school. Now, where my daughter is teaching in the school, and I'm not going to name where it is because that would not be nice, they force them to give the kids a 90 or above in order to have high GPAs, even if they're not doing the work. And so we may be getting some people into schools that are actually not good students, but because they're in schools where, you know, back in the 70s, the admission to that school was $1,800 a month. So, you know, it's kind of a little bit higher now. So we may be getting some people who are going into schools just because they got a high GPA. And then also I wanted to know, are you guys doing anything as far as monitoring the people who are locum tenens people, you know, who are just going from one hospital to another hospital to another hospital? How do you catch up with those people? Because sometimes when you call the medical board, you can't even find that doctor as having a license or something of that nature. And one final thing, and I'm going to land the plane. We are saying something about the fact that we don't have certain types of specialists here, but when it gets down to it, our coroner's office right here does not have the ability to do paraffin. I'm talking about in the state of California, to do paraffin testing on DNA. So we got we can't even test dead people. So because they recommended us to go to Europe to get somebody to do it. So all I'm saying to you is that we have to catch up with some things that are taking place all around the country and the world in this way. But we really need to find out who is monitoring whom. I'm going to shut up. God bless everyone.
Thanks for your comments.
Okay. I know, I think on monitoring, that's maybe more the board, but I think you do raise an important point about locum tenens. What I will say about language is UC Irvine's PRIME program is focused on preparing physicians to care for the Latinx population. Anyway, they do intensive language training. And there are some other examples, but I think that's a place where there's more that our medical schools and our residency programs could do for intensive language training for learners. And again, that might be a place where HCI might, you know, if resources were available, if the state legislature and the governor provided resources, that HCI could provide funding to schools to do a better job of intensive language learning and training.
Thank you. Other comments from those in the room? WebEx, please, Sean.
Anyone on the WebEx would like to make a public comment, you can use the raise your hand feature, or you can just type anything into the Q&A box and we'll call on you. You don't have to type in your actual question. And if you're in a call-in only line, you can press *3 in order to queue up in order to make a public comment that way. First up here, we have Rosie Arthurstetter.
For your work. I'm a researcher of many, many decades, and I'm a patient advocate. I've been attending these meetings for a decade. And actually over the last 3 decades, I've seen a huge shift in how patient care has come from where there was a good majority of private practice, and now pretty much everything is corporate practice. We have the issue of different venues. We have VA, we have workers' comp, we have other venues where the same word in each venue means something else and may deny you getting access to treatment. And I think your research here is to look at the pool of available physicians to actually treat patients. And what it's sort of like going to Disneyland. You might go there for 8 hours and come out exhausted. And when you look at how much time you enjoyed the rides, it's maybe 30 minutes. The rest of the time was in line or walking around. For a patient, these days, anything beyond the basic, they are referred out to somebody else who is not going to treat them. They are only going to see them and refer them back to their primary care, who is not going to treat them. It took me 8 years to get approved for a medication called Provigil when it went generic. 8 years for when I had taken, then they wanted me to spend $1,300 a month for a 30-day supply when it was only $40 at Costco for 90 days. 8 years for that. People with genetic ailments like alpha-1 antitrypsin deficiency, which affects more than the lungs and the liver. It affects bleeding and clotting. And what happens is if you have one of these patients, they may be healthier than you know, but something overwhelms their
30
ability
seconds remaining.
to manage it, and they get referred out to the wrong people. I think one of the problems we need to look at is how do we find a way to improve the access to the physicians who actually can treat patients, or make it so that a physician is not intimidated to treat their patient. Thank you.
So thank you very much for sharing your story. And it is very, very sorry to hear just how much you have struggled to get the treatment you need. I think what I would say is I think the work that we're doing here with the medical boards and so on is really telling sort of the supply part of the access story. And it's an important part, but I think what you're sharing is that there is a part of the story and the challenge for access that isn't about supply, that it's about insurance and what those insurance regulations say about who's in the net, about how referrals are made, about what's covered and how it's covered for medication. And so, and which specialists and environments are in the network, and the network you have available through your plan. And those are really, I'm just going to call out those, I don't have answers for you, but those are really, really important dimensions of access, I think, certainly for the medical board and for Department of Managed Healthcare and other stakeholders to really be attentive to.
Thank you very much. We ask the callers to please stay focused on the subject at hand, this agenda item.
Next up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt on your end. Morning, Marion. Looks like your line's open.
All right, thank you. You can hear me?
We can. Yeah, please
Okay,
go ahead.
thank you. Thank you very much. Good morning. This is Marion Hollingsworth, Patient Safety Advocate. First, thank you for this report. It was very informational. The survey does give some important information overall, but what would help consumers quite a bit is a picture of the doctor on every profile page on your website. Since many doctors don't state a race, it would be helpful for consumers who would feel more comfortable with someone of their own race. Even names aren't always a good indicator of race. I encourage you to add a picture for doctor applications and renewals to help consumers see age or race and better be able to make a decision on a healthcare provider. A picture could be updated every 5 to 10 years, just like a driver's license or passport. Some doctors do have pictures online, but many don't, and it would be helpful if the medical board would require this. Thank you.
Thank you.
Thank you for your public comment. At this time, President Hawkins, I don't see any. Michelle Montserrat Ramos. Give me just a second to send you that request. Michelle, you should be seeing that here shortly.
Ramos, and I am not speaking on behalf of my organization. I'm speaking as a state and national advocate, and my comments on this agenda item reflect only my opinion. I found the speaker's comments as to why there is a shortage of Latino and Latina doctors somewhat offensive. As an educated Latina who graduated from a UC school and was accepted into a UC master's program, who was engaged to a Latino who was a UC graduate who died due to medical negligence, I do not believe that our shortage of Latino doctors has anything to do with our assumed low economic background. Granted, most of my community are not Ivy League legacies, but to stereotype an entire community to claim that we come from an underserved community and from parents that lacked higher education and not supportive of higher education is somewhat offensive. As Latinos, we face racism within our K-12 educational system, specifically in high school. We are discouraged from attending college when many of us specifically told that we are not college material and should seek employment working with our hands. What I can say about our immigrant community, brothers and sisters, is that they are very determined to seek higher education and do so. And I believe that they reflect a higher number of college retention and college graduates in the state. What I do believe, what factors that contributes to the shortage is the end of affirmative action in the state of California. Thank you.
So thank you very much. And I deeply regret and apologize if I gave that impression of stereotyping. And I think I started by saying that the structural racism is the issue. And I think everything you said is absolutely true. I would say I think it is, the socioeconomic issues are also there and real, but I think, yes, regardless of where Latinos are in California are on the socioeconomic ladder, they face racism and stereotypes about what they're capable of achieving that certainly affect the opportunities that are available to them. And I do think, yes, the end of affirmative action is certainly an important issue. I guess maybe I've been around long enough that as important as that is, it's also something that happened in the late 1990s. And, you know, the voters were given an opportunity to repeal that in 2020. They didn't. The Supreme Court, I think, has, you know, I profoundly disagree, but the Supreme Court, I think, has told us that affirmative action is not permissible. And so I guess the way I look at this is, in a world where we are constrained from an affirmative action, what can we do? And I think we do have some examples, and Drew is one of them. I think the Compadre program at Davis, I think many of the prime programs are examples of when we really look at what are people bringing to medical school. It's Latina heritage, it's Spanish language, it's that culture, that where we have been intentional about that, we are seeing more Latino students enter medical school and residency, and so thank you very much for your comment and reminding us of all of the complexity.
Well, that's the end of our WebEx. Dr. Kaufman, I really want to thank you very, very much for coming before us and giving us a lot of food for thought and asking us to say, how can we be of service in whatever way we can? And we hope to see you back again soon.
Thank you.
Just taking a 15-second breather here. Okay. Moving to agenda item 12, second annual progress report of licensed physicians from Mexico pilot program, Dr. Sergio Aguilar Galaxa. Welcome.
Thank you. Well, it's great to see you again. I was here almost a year ago. I think that it was virtual at that time. I'm glad to be here in person to share with you some of the highlights of our second annual progress report for the Latino physicians from Mexico pilot program. And but you know, it is great to hear the discussion that you had in the presentation by Dr. Kaufman, who has been at the forefront providing us with information that is pretty much relevant to the supply side of this balance with the need and the demand that we have. And I'm so pleased that she presented very compelling data on the needs and some of the medically underserved by county, which is one of the slides that I was, is not included in the slide deck, but I was going to talk about that. So I'm glad that she presented that to underscore the tremendous need that is out there. Something that, I'm from UC Davis, Center for Reducing Health Disparities, and I'm a researcher, and I have been doing population-based research for decades, documenting the barriers of access to care and the tremendous need that some populations, especially in the rural areas, have. So thank you, Dr. Kaufman, for and I'm going to ask you for the slides later on because you have been providing updates. She and I at one point coincided with the California Future Health Workforce Commission, and she fed the commission with very important information. So next, and I presented some of the slides just to put things in context last year. And this is a little bit of information about the licensed physicians from Mexico pilot program, which is meant to be on the supply side. It is given the tremendous disparities in access to care and utilization of services. This is one more solution, of the ones that you briefly discuss and you engage in the wonderful conversation that you just had. And I won't get too much into the details because you know the background, where is this coming from, and that it really attempts to address the shortages in primary care, especially in the rural population, actually in the rural populations. So next. This is some of the challenges. I don't have to get too much into this because Dr. Kaufman was, provided plenty of details about not only the distribution of physicians by county, but also the breakdown by race and ethnicity and language as well. So one thing that I want to emphasize, however, is that the supply is not looking that good given the demand that we continue to have. Even though we have the great news that Charles Drew, has a new medical school. I'm delighted that that is the case. Kaiser Permanente as well, that is being implemented. We are working with them as well. But looking at the crystal ball in terms of including UC Davis, that we have the Compadre program that Dr. Kaufman mentioned, is going to be very, very challenging to catch up with the demand. And one of the things that we have down the road is just the percentage of physicians who are going to be retiring within the next 10 years. And that we don't have a way to replace them, actually. So these are things that we definitely need to consider. Next. This is just to touch base with you in terms of the evaluation. Our Center for Reducing Health Disparities is doing the evaluation of the Latino Physicians from Mexico pilot program. And what I'm about to present to you, as I mentioned at the beginning, are some highlights of the second annual report. Okay, and this is, there are 6 outcome measures that we have been focusing on. And what you see in the slide are the specific measures and the areas that we had been evaluating. And number 7 in this outline is about the recommendations that we are going to be providing to you about whether the program should be continued, expanded, altered, or terminated. But I'm very pleased to be sharing with you that the second annual progress report has some, it captures, to a great extent in some of the dimensions that I will briefly discuss with you, the positive progress that this program is doing. I want to emphasize also that we have been independent, an independent evaluator, and I want to thank Carrie, Marina, Reggie, for the support that we have gotten to remain an independent evaluator as well. Next. This is a framework that I want to, I won't get into the details, but there are 3 specific domains, that you can see in the columns, from patient outcomes and physician outcomes and organizational and clinic outcomes. And within each of those dimensions, you can see in this framework, there are specific measures, the dimensions that we have been evaluating, very specific instruments, the metrics that we are using to tap into that. And then a little bit of a idea about the timeline. When is it that we are evaluating the various outcomes? Today, I'm going to be presenting what we evaluated most recently, and not only in a quantitative manner, but also in a qualitative manner that has been extremely rich. And I'll share with you once again some highlights. Next. This is a different way of representing the work that we're doing. We call it the LPMPP conceptual model. And there is linking the instruments with the specific outcomes as well in a more dynamic manner. All of this is interrelated, by the way. Next. Just as a refresher, the board has approved 30 physicians coming from Mexico. And I got an email. Marina, I got an email from our program manager that you granted the license for the 30th of those physicians. And this is the way in which they are distributed by the 4 community health centers that you can see in the slide. Altamed Health Services has 7 physicians assigned. Altura, Centers for Health in Tulare, also 7. Clínica de Salud del Valle de Salinas, which has the most of the physicians based in Salinas, and then San Benito Health Foundation with 5, which is based in San Benito. And the slide that I was going to describe to you and that Dr. Kaufman, presented to you had where these 4 clinics are localized. And there is a relationship with the distribution of primary care doctors in those areas. And in some of the areas, like in San Benito, there is a relatively low number of primary care physicians compared to Los Angeles, for example. But, Altamed, who is based in LA, there are tremendous needs for the Latino populations, especially there. And by the way, just to let you know that based on the latest census that was released just a few weeks ago, in California, 41% now, 41% are Latinos. And 75% of those speak Spanish. So it is just remarkable in terms of the need that exists in our state. Next. This is just to give you a sense of the timeline of the physicians coming from Mexico, their arrival, and when they started working at their respective community health clinics. And just, what is coming out of the slides is that originally we thought that we were going to evaluate a program in which most of the physicians, at least, were going to arrive. But this has been staggered, by necessity. I totally understand. But this has posed some challenges also on, how we go to evaluate and the timing of the evaluations. So what I'm going to be presenting to you includes only 3 of the 4 community health centers. We don't include data on Altamed yet. But now is Altamed, which came later. We already are working with them to do the evaluations with them as well. Next. This is another timeline. And it's just to once again, with a little different information there, but it is just to give you a sense, once again, of the staggered nature of when the physicians are joining this program. Next. The other thing that I really want to emphasize, because it's been a very important addition for our evaluation, is the qualitative, in-depth interviews. We are working with 3 colleagues who are evaluators. That's what they do, who are fantastic. And what they did was to do in-depth interviews with the number of 13 administrators, and you see the numbers there. And it was very rich. And we included many quotes in the report itself and in the slides that were sent to you also. There are 3 slides with quotes that we selected to give you kind of a sense coming from those that were interviewed about their experiences with this program. Next. So I'm going to read this couple of, bear with me, but it captures some of the flavor of what the qualitative interviews, the in-depth interviews, are rendering. It's more than quality care for me. It's more than the metrics. All patients deserve to be recognized and accepted for who they are. And I think these providers, that's what they bring. The community received them really, really well because they see basically the quality and the cultural sensitivity, and everything has been excellent. Next. They just have that heart that you could train them on the immunization schedule. you cannot train them on having that heart. There's all kinds of things that are happening with our patients when they walk in. And for them to be that is and lead with a sense of ownership that they have their doctor, that they have their clinic. That is extremely important. Next, the last couple of quotes. They are providing not only a care that's consistent with our standards, but they are adapting to the setting well. They are being integrated within the team and the patients. We have a lot of monolingual Spanish speakers as well. And so culturally, it was just a perfect fit. And again, it was taking us many years to even hire a doctor. They just don't want to come, especially to rural areas. This is one of the challenges that these particular clinics have been facing in serving the populations that in their catchment areas in a way that responds to the needs and the numbers that are needed to provide the services. Next. This is just, we implemented the 360 assessment for staff. This is part of what we evaluated. And just a little bit of information about that particular instrument that we use, which is based on the ARC Medical Office Survey on Patient Safety Culture. It evaluates patient-provider interactions and provides an assessment of the work environment and attitudes and experiences about patient care. And this is over the past year. Next. A little bit more information about the instrument, and we did it for staff. And we included in the 3 clinics that I mentioned to you, it doesn't include yet Altamed, and we did it with 219 participants from the 3 clinics. Next. This is a little bit of the profile of who participated, the demographics, who participated out of the 219. You can see most were women, 3/4 identified as Hispanic or Latino. The greatest majority are of Mexican or Mexican-American origin. You see school attainment, also 1/3 health clinic positions such as therapists, medical assistants, 1/4 health administrative or clerical staff positions. About 8% were physicians and about 4% physician assistants. Next. So these are some of the findings in terms of quality of care and these are some of the highlights. Once again, 90% of participants rated their medical offices, systems, and clinical process as good or better. And this is related to preventing, identifying, and correcting problems that could affect patients. 88% of participants rated patient care as good or better. In terms of the adaptability of physician, 88% rated patient-centered care as good or better. Next. In terms of working and administrative environment, 85% of staff reported being able to ask questions when something does not seem right, which is great as an environment. I think that is important that happens. In terms of the impact on interpersonal relations, 80% of respondents believe that there is a positive teamwork environment in the clinic. Next. In terms of knowledge assessment, and just to give you a little bit of a context, this is that assesses the Latino physicians from Mexico pilot program knowledge of the California medical standard, something that has been of critical importance as well. This is a structured questionnaire that was developed based on the 6-month orientation course that the physicians from Mexico completed. And the questionnaire consists of multiple choice, multiple response, and true and or false questions. Next. It's a little bit more information about the specifics of the instrument itself, but also of who took it as well. It was administered to 22 out of 30 physicians between March and September of this past year. And one of the highlights that I want to share with you is that the licensed physicians from Mexico demonstrated a solid understanding of the California medical standards with an average score of 87%. Next. So there are several takeaways, just to summarize, that I want to share with all of you. This is in terms of the qualitative research based on the in-depth interviews that were done with the 13 administrators. Most administrators believe that the LP MPP project has been a valuable undertaking to their community health centers. The physicians are adapting seamlessly to the clinic environment. The integration of the Mexican physicians is anticipated to enhance clinic productivity, resulting in what all want, certainly the clinics, in greater access to healthcare for their patients. And then the alignment between the cultural beliefs and customs with the integration of the Mexican physicians in the clinic has led to an increase in patient trust. Actually, there are several quotes that were collected related to that. And some of them I have heard, actually, Secretary Lourdes Castro Ramirez, mentioning some of the quotes that she directly heard from patients as to what that means in terms of the services that they are receiving in Spanish and with someone that they can relate to in terms of the culture as well. Next. Another takeaway, and this is specifically to the 360 assessment for staff. A vast majority of staff express a strong satisfaction with their medical office systems and clinical process. Staff demonstrated exceptional resiliency in supporting patients despite facing numerous competing demands, especially during the COVID pandemic. The majority of staff express confidence in their ability to provide high quality of care to their patients, and staff felt comfortable asking questions and expressing concerns, and they believe that the team environment is highly supportive and constructive. Next. So this is both for the knowledge assessment that the Mexican physicians demonstrated a strong understanding of the California medical standards, and overall, the program has a strong positive feedback from all that participated in the evaluation. Physicians integrated seamlessly, making healthcare more accessible and increased patient trust. Staff reported excellent patient care processes in a supportive environment, and the physicians demonstrated a solid understanding of California medical standards. Next. So what's next? This is what we have in store, just to share with you, that we are going to go to the other measures that measure other dimensions, like the class assessment for staff and patients. By the way, class stands for Cultural and Linguistically Appropriate Services Standards. Something that we had been working out of our center for almost 2 decades as well. Also, we are going to continue to do the 360 assessment for staff and patients. In this case, we are going to include patients, knowledge assessment of the Mexican physicians, and then we'll do qualitative data collection. And we anticipate doing several focus groups with 6 to 8 physicians. And this is something that we are actively working on to develop the focus groups guides in order to do the work. Next. This is just that I want to recognize, it's been really great overall to work with the community health centers. They have been very cooperative. And when we have encountered some challenges, we have openly discussed them and overcome them as well. So it is not only we are grateful to the leaders of the community health centers, but the patients as well that have been also cooperative as well. And also to thank Reggie and to thank Marina, Dora, and we should have included you, Carrie. We are very grateful to you as well. And also our team from the Center for Reducing Health Disparities. And the person highlighted is Jill Lopez-Rabin, who is, the program manager for this program, and she was unable to be here. She's dealing with an emergency, taking her mom to the hospital. She wanted to be here. So I'm going to stop there, and these are just highlights. There is a lot more details in the report itself, but you are always welcome that any comments that you have, either to reach out to us, and your suggestions also are most welcome. And I was heartened to hear how you were brainstorming in terms of how to really come up with potential solutions for the tremendous needs that our populations, especially in the rural areas, have here in California. And I would love to continue to hear your thoughts. Very, very fascinating thoughts as you share with here with the audience. I'm going to stop here, and if you have any comments, questions, you are most welcome.
Well, thank you very much for that comprehensive update on the second annual progress report. I found very helpful quotes from the in-depth interviews and assessment of the staff as well. But I wonder if you'd be willing to summarize really what you believe the impact of the program is having in your own words, just the big picture. What's the impact of this program?
I think that well, thank you so much for the question. Up to now, and we have once again strived to be an independent evaluator. Is positive. Is very positive. There is there is needs that have been unmet that are being met with some of the populations in the catchment areas of the of at least the 3 community health clinics that we have included. So I would say so far so good. We still have more year to go, but what we have been able to ascertain that there has been even improvements, from compared to last year. So it is a positive outlook. You're welcome.
Thank you very much. Are there comments or questions from the members? Dr. Blat?
Thank you for providing this really excellent work that you've done for decades, and it's always so illuminating. I would just say from my experience as the executive director of the UCLA International Medical Graduate Program, which is basically put 175 physicians, 45% from Mexico and the others from Latin America, that I think these findings that you have will demonstrate once again the extraordinary impact that these doctors have. They're actually raising the boats within the residency programs that they're actually involved with, because that bi-directional, bicultural diversity that goes on. And we know from the literature, right, that if you have a more diverse class, be it in medical school or in residency, you create really much better physicians and with a deeper understanding. So I think that that I want to mention something about the structural racism. That is real. I think the doctors do face that. And yet, I would say of the 175 graduates that I have now, that they've gone on as to be chief medical officers, to be frontline physicians, and have provided well over 1 million access to 1 million patient visits. So this program is yet another opportunity to really learn from each other. And I think in this world of trying to unify, I think this is a really important work that you're doing. So Dr. Gaxiola, gracias.
No, thank you. Al contrario, muchas gracias. Thank you so much.
Well, thank you very much a lot for helping with that. Other questions or comments? Ms. Lubiana.
Thank you. It's always a pleasure to have you here.
Thank you so much.
I have an easy question. So for the program, the physicians that come over, do they have a choice of where they're placed?
I think that is better answered by the board, because we don't have any input in terms of where they go. So I would, but it's a great question. We have asked ourselves the same. So maybe Carrie or Marina or Reggie, that you can help us elucidate that.
My understanding is that there's an interview process that they go through with the clinics, and there's 4 locations, so little choice. And Marina, do you have more insight on that?
Yeah, I was just going to add, so the program implementation is partnered with UNAM. So in Mexico, they help recruit the physicians for the program to match them to a clinic. And as Carrie said, there's an interview process, there's orientations, there's requirements. It's a pretty long, thorough process. So there's different groups working to find them, match them, and to make sure they meet the clinic's needs, of course.
Got it. Thank you.
What I can tell you is that what the data is providing is that they are highly selected primary care physicians from Mexico. And UNAM, Universidad Nacional Autónoma de México, is the largest university in the Americas. They have almost 400,000 students, and they really have for centuries, had been in existence for centuries. They strive to not only highly select the physicians that they are sending us, but they have been extremely cooperative as well. The dean of the medical school in UNAM has been a champion for this, and the specific colleagues out of UNAM that we have been working with as well have been very professional, very collaborative as well.
Thank you.
You're welcome.
Are there other comments from the hearing room? In the hearing room, rather? WebEx? I'm sorry, Mr. Watkins.
Thank you. This was amazing again. And I'm so glad that this program is working out. So my question is, what's the end point when will you continuously evaluate this? And the second part of the question is, and I don't know if I ask you, how do you scale this if there's such a positive outcome?
Yeah.
The need is so great and pressing.
Yes, I don't have a response for you for the first question, if this will continue to be evaluated. But the second question is, I think this is, once again, one more solution or possible solution to the tremendous need that California's populations have, especially in the rural areas. And I know I'm aware of other possible solutions as well. But I think that because the supply is not gonna, looking at the crystal ball once again, is not gonna meet the demand for the foreseeable future. I think that is important, of critical importance, that we look at ways in which, for example, if this continues to be as successful as we are documenting so far, that it is how to scale that up, for this particular project. But I think I see all of you very committed to the importance of how to meet the demands of the population, and that we need to continue to brainstorm and to try, as many solutions. I heard from you directly some of the solutions and other possible solutions about getting other people to learn Spanish, which is for these populations is of critical importance. Once again, here in California, 41% Latinos, 75% speak Spanish at home, and many of them are monolingual, Spanish speaking. And there are other population groups, for example, indigenous populations like Mixtecos, Zapotecos, Triquis, which are a sizable number. And that, for example, in the case of Mixtecos, there are approximately 175,000 in California, and 80% of them speak Mixteco only. They don't speak even Spanish. So there are tremendous needs at the population level that we need to bring our best ideas together and collectively look at what is it that we can possibly do to meet the needs of these populations.
Thank you. Any other members? Dr. Sai.
To piggyback on Mr. Watkins' question on endpoint, I know that the first group of physicians came over in 2021. So next year will be their 3-year limit. What's the process? There's their ability to extend, renew? Because now they're onboarded, they're in the system, they're doing well. And if their limit is 3 years and we have to bring a new group of doctors in, the whole process begins again. And, as we all know, the process might be more costly than just having, the current physician stay. So what's your sort of endpoint on what's the current group of physicians, their plans? And
That's a great point. I think that it makes a lot of sense that those who are already here and that they really have become familiar with the system and their system of care that they are working in, that their time is expanded, but also 30 is kind of a drop in the bucket, as Dr. Kaufman was very clear in terms of the outlook that she presented, that an expansion would be advisable as well. But we are the independent evaluators of the program, so we don't. But certainly we have opinions about that.
Can I just add to that? So right now it's in statute that it's a 3-year limited license. Any extension or, expansion of the program would require statutory change. There was recent legislation enacted that allows any of the physicians who had delays in their ability to start practicing because of a medical issue, delays in credentialing, they can submit starting January 1, just for 1 month. They have a 1-month period where they can submit a request for an extension up to a year. So we'll actually probably be receiving some of those requests starting in January, but that's, again, it's only up to a year, only if it meets certain criteria. So it's not really an extension of the program. It's just for them to be able to make up any time they lost in their ability to practice because of those certain circumstances. So.
Thank you. Any additional board comments? Hearing room, do we have comments from anyone? Yes, come forward, please, regarding medical pilot program.
I am praising Dr. Aguilar-Gaxiola for the work that you're doing. I think this is such a good thing. The United States needs to get over itself. I'm from a family where there were people here at Azteca in the year 1050 back in Illinois. So, I mean, people are here of all types. So it makes no sense for us not to accommodate. And when you made that statement, we need to recognize people for who they are. That hit home so closely with people. And one of the things that we also need to realize that in our facilities, often in the medical facilities, they're doing Latino people the same way they were doing Filipino people back in the 1980s. You could be a nurse, which is fine to be a nurse, but they were not letting women come forward and men come forward and take on the other positions. And so, and a portion of it has to do with classism and racism. And we, again, back to what Dr. Kaufman was bringing forward. If we can treat the youth early here in this country, we can also have the youth learning early in other countries so that they can come into this country. And it's no reason why they shouldn't be able to have dual residences and go back and forth. They let the people who are very rich, the billionaires, come and do what they want to do and come back and forth. So why not doctors? It makes no sense that, oh, you got a 3-year license in, bye. No, it makes no sense whatsoever. So it should be, an integral portion of it should be that they should be able to come back and forth, just like a real estate owner would be able to do, or a construction owner. Enough of me. God bless everybody.
Thank you.
Thank you so much.
Any additional ones in the room?
Your comment resonates very much with me. Thank you for sharing.
Thank you. WebEx?
Any WebEx attendees would like to make a public comment, you can do so by raising your hand or typing anything in the Q&A window. We'll call upon you. If you're on a call-in only line, you can press *3 in order to raise your hand as well. Give everyone a few seconds to see if anyone's interested. This time, Dr. Hawkins, I'm not seeing any requests.
Thank you very much, and thank you very much, Doctor.
The contrary. Thank you. Appreciate it.
For those who came on late, agenda item 13 was canceled due to an emergency of the speaker, Mr. Lombardo, and his presentation will be rescheduled. Our next agenda item is 14, discussion and possible action on the online complaint tracking system. Mr. Sean Eichenkraut. We're going to take a 10-minute break to give our presenter a chance to set up, and folks can do whatever they need to do in 10 minutes. Our next agenda item is discussion and possible action on the online complaint tracking system. Mr. Eichenkraut and Ms. Kramer.
Thank you, Dr. Hawkins. Sorry, give me just a second here to get the presentation up. Pulling double duty right now for you. All right. Thank you, Caesar. Good morning, everyone. Thank you for having us today to provide an update on the complaint tracking system proposal. We'd like to catch you up on some of the efforts since we last discussed the proposal with the full board and present you with an updated proposal on the features and requirements we are suggesting for the minimum viable product. Hopefully, we can obtain your approval to officially begin the project approval lifecycle process as required by the State of California Statewide Information Management Manual. This came up earlier in the meeting. We held 2 interested parties, one on March 6, 2023 and on June 21st, 2023. The idea was to provide a dedicated and extended opportunity for public comment on the presentation given at the May 22nd board meeting, and to allow for public suggestions on additional functionalities desired in the proposed system. Ms. Lubiano and Dr. Bolad attended both meetings, providing suggestions of their own and assisting in taking public comments and documenting suggestions. Recordings of both meetings are available on our website. I described the discussions as productive and beneficial in that they gave the opportunity to hear a wide range of suggestions that, while related to the enforcement of complaints, or while related to enforcement and complaints, did not fit into the concept of a portal for a patient or authorized representative to be able to view the status of the complaint that they submitted to the board. Some of the suggestions requested aggregate and or detailed information about complaints for the same respondent that were submitted by other individuals, or collecting information from the complainant that would be better suited to be captured during the initial complaint filing. Discussing these suggestions, though, in the meeting aided us in further clarifying the objectives for the proposed system in the next slide. In total, 27 suggestions were documented, including those from Ms. Lubiano, Dr. Bolot, and the public attendees. Each requester described their suggestion to myself and Nicole, and we captured their suggestion in a tracking list, asking probing questions if necessary to ensure we captured the essence of the request being made to the agreement of the requester. All suggestions were reviewed for technical and legal feasibility. Many of the suggestions have been incorporated in the proposed functionality update in the upcoming slides, but several were determined to be outside of the scope of the complaint tracking system proposal, either because there was a technical reason for accomplishing the request through another mechanism outside of the complaint tracking system, or for legal reasons the request could not be fulfilled. While we will not be addressing all 27 of the suggestions individually during this presentation, the suggestion tracking document was published along with this presentation as a material for agenda item 14 for those viewing online, available from the board's website. The board's response to each individual suggestion is available in that document. So from the original presentation, we kind of clarified some of the objectives here from the interested parties meeting. The first bullet here, we wanted to clarify the intended user use case and the scope of the system. Patients and our authorized representatives on a complaint will be the only ones able to access their complaints through the system. Information about pending complaints other than the complaint currently being viewed will not be available, as is prohibited by Business and Professions Code and Government Code sections. The scope of the system will be limited to the individual complaint that the user is accessing. Users that have submitted multiple complaints to the board will be able to view all active complaints through the system they've submitted, but each complaint will be accessed as an individual record. Some sample wireframe mockups will hopefully further illustrate this point in the upcoming slides. Minor modifications to the other objectives were made, but not really to change their meanings. We wanted to give users the ability to check for updates anytime it is convenient for them, leverage email notifications from Breeze to inform them of changes faster than traditional paper letters sent via postal mail and outside of traditional business hours. Any reduction in the amount of calls enforcement staff and investigators receive translates directly into more time they can spend on complaints and investigations. This is pretty much exactly the same privacy and security slide from the original presentation. Again, just here hammering home the fact that the scope is only going to be that a user can only access complaints that they have submitted. Not included in the sample wireframe mockups we'll look at here in shortly is the actual user interface for accessing the system. The part where you enter in your email address and the complaint number that you're trying to access, and it will email you a code that you use to access the system. I think everyone's familiar with that type of, passwordless authentication that's used commonly today. So we wanted to kind of look into more details on the actual data available in the system and how we'd like to present that data, give you an idea of how that would work. Just trust it's the same way that you use pretty much any multi-factor authentication system nowadays. Last time we talked about this list of elements, but today we'd like to take you through the proposed segments of a sample wireframe mockup and then look at a couple of full-length examples. Please keep in mind these sample wireframe mockups are essentially artistic renderings of what the proposed complaint tracking system could look like using a common industry standard user interface framework called Bootstrap. Since the proposal has not entered the project approval lifecycle process as required by the state of California's statewide information management manual, there's no programming logic behind these samples. They're just static renderings of sample data for illustrative purposes, just because a picture is worth 1,000 words, right? So it's easier than trying to talk through everything. I just want to be 100% clear. These artistic renderings could look completely different than, style-wise, artistically, what the official system might look like. I just threw these samples together. It's more important to see the data that's in there, not exactly get hung up on how the styles look. We won't go into design detail till later on down the road, assuming the project gets approved today. So this is an example of the top segment that we're just kind of calling the complaint information header for now. Sample wireframe mockups here help illustrate a couple of elements that relate to suggestions from the interested parties meeting. The status indicator indicated by the green open symbol up at the top right of that header window can toggle back and forth when a complaint is open or closed. So not only just showing open or closed, but a little green effect to it, switching from green to red to let them know that, hey, now this complaint has stopped progressing anywhere. The respondent's license will be presented as a hyperlink to the DCA search profile for the respondent view or of the respondent for viewing through the, the respondent's license will be presented as a hyperlink to the DCA search profile of the respondent for viewing throughout the availability of the complaint to the complaint tracking system. So if you click that, it's probably maybe hard to see, but the under the respondent's license there where it says physicians and surgeons AA 231201, if you were to click on that link, it'll actually take you right to the DCA search profile, so that if any point during the life of the complaint you want to review that physician's profile, it's right there in one click. We talked previously about the enforcement phases in the last presentation, and one of the requests was to have kind of a where you're at in the process view. But since no two complaints are the same, it is pretty much impossible to determine the path a complaint will take through the complaint process. At the highest level, a complaint can potentially traverse through all of these phases and sometimes through a phase multiple times in varying cyclical patterns. The receiving and disposition of a complaint will always be the bookends, but what happens in between is determined on a complaint-by-complaint basis. Many of the activities during the central complaint unit phase will be available to the user, but if the complainant advances to later stages in the complaint process, the user will be privy to fewer, less frequent updates due to the nature of these phases. For example, activities of the investigative stage are exempted under Government Code Section 7923.600. The current status and past activity history will remain available as long as the complaint is open and for a to-be-determined amount of time after the complaint is closed. The final length will be configurable so that a value can be finalized when the official requirements are documented during the project approval lifecycle process. To mimic the capabilities of activities in Breeze, there are two distinct activity types in the proposed complaint tracking system, what we're calling point-in-time and start-to-end activities. Point-in-time activities are activities that happen on a specific date, and aside from that date and the name and description of the activity, there's no separate disposition information. Start-to-end activities are activities that started on a specific date. These activities have a starting meaning and eventually one of potentially multiple possible ending dispositions. If an activity disposition has not been entered yet, the activity will appear with a yellow background and the disposition name will appear as pending. Once an activity disposition has been entered, the activity will appear with an activity disposition configurable gray, green, or red background along with the activity disposition name and description. The background color for an activity disposition can be independently configured by logical outcome. Green equals positive, red equals negative, or could default to a gray color. All the colors and samples are here, again, from a standard framework called Bootstrap that we use, but they could be changed to just for illustrative purposes. So the easiest example of a point-in-time activity is the complaint received. The complaint received activity will show on every complaint with the description of the complaint was received by the board and entered into the Breeze system with the specific date the complaint was received and a count of how many calendar days have occurred since that date. The name of the activity along with its description appear with a single date associated with when the activity happened. There's no indication that there's an activity disposition for this activity because the complaint being received is the total of the activity itself. The light blue color is also used to indicate that this is an informational point in time activity. For a start to end activity, the first example that came to mind was a request for medical release from a patient or authorized representative. The request for medical release from patient or authorized representative will first appear on a complaint without an activity disposition while the central complaint analyst is awaiting response from the patient or authorized representative. The arrow icon is used to indicate this activity will have an activity disposition added when applicable. The pending entry is used as a placeholder to indicate that there is not currently an activity disposition, and the yellow background color is intended to let the user know that this is an activity to keep an eye on for updates. The descriptions for activities can be figured to have popover definitions for key terms, links to other board web pages with additional information about the complaint process or other processes, or in this case, links to forms, and can contain information about legally required or internally developed response times for applicable activities. That was another request that came out of the interested parties meetings. The names and descriptions in these samples have not been finalized and will be able to be configured independently from Breeze to ensure that they can be changed rapidly to relay the most beneficial information to users. Pending start to end activities will not have an end date until an activity disposition is added. So as a sample of that, if the central complaint unit analyst does not receive the release within the procedural expected amount of time, the no response disposition is added to the activity along with an end date. The activity will turn red and will show no response for medical release from patient or authorized representative. And again, we can have in that description hyperlinks to what to do about that, all kinds of additional information. These are just initial descriptions we put together. If the central complaint analyst does receive the releases within the procedurally expected amount of time, the received disposition is added to the activity along with an end date. The activity will turn green and will show the request for medical releases from patient or authorized representative received. Changing the activity disposition replaces any prior activity dispositions if present. A convenient way that users could contact the currently assigned staff member or unit regarding their complaint was an originally planned requirement. Initial thoughts were to display the currently assigned staff or unit name, email, and phone number contact information. But in discussions during the interested parties meetings and internally, a requirement materialized to log contact requests from a user for documentation purposes. This requirement could not be achieved by directly providing the email and phone number contact information to the user, as direct emails and phone calls could not be automatically logged into the system. But by using a contact form as proposed here, we can relay the message directly to the assigned staff or unit while at the same time logging the contact request into a database. The user would receive a copy of their request for their records and a response from the currently assigned staff or unit when appropriate. For the initial minimum viable product proposal, the complaint tracking system will not be able to insert this information directly into Breeze, but we do plan on tracking all requests and responses in an adjacent database for the later enhancement to add the functionality to Breeze required to insert this type of information directly into Breeze as an activity itself. So to put all those three segments now, the header, the list of activities, and the contact form together to see what a complaint would look like in full, we put together a couple of examples, and they're based on real complaints, but the identifying information was obfuscated for confidentiality purposes. In this first example, we view a complaint that spent a significant amount of time and has a significant amount of time and has a significant amount of activity in the central complaint unit. The top of these interface will be the complaint information header with the specific details of the complaint that the user authenticated to view. At a glance, we can tell that the complaint is closed and there's a link to the respondent's DCA search profile, always available for them to view. At the top of the unit, the user can scroll down to the complaint activities. There's a badge in this case indicating 11 activities are listed. While the activities will be sorted in chronological order by start date, this is a good illustration of activities that can be happening in parallel and in series. While this complaint was assigned to a central complaint analyst for approximately 21 months, the user could see additional activities happening concurrently during the time frame below. In this example, you can see multiple medical consultant program review records requested from the subject of the complaint and requested records from the hospital activities, which can commonly occur while the information is being collected and reviewed in the central complaint unit. So you can see how the cyclical activities can happen over and over as the complaint is progressing through the central complaint unit. Ultimately, in this example, you can see the complaint was closed for insufficient evidence after the third medical consultant program review. At the bottom of the user interface, the form to contact the currently assigned staff or unit is available to send a message, and all messages would be logged in the database, so the history of the message and the follow-up and response, or if applicable, can also be documented. The second example will view a complaint that initially progressed through the central complaint unit very quickly, but then spent a lot of time in the investigative stage and ultimately resulted in the filing of an accusation and revocation of the respondent's license. Again, same header information up there. It shows, at a glance if it's open or closed, and that link to always check out the respondent's profile on DCA search. Again, the badge here indicates there's 11 activities to view, and right after the point in time complaint received activity, the complaint gets referred to investigation. Right after that being referred to investigation, it gets assigned to an HQIU investigator for approximately 16 months. While there are activities being tracked during that time frame, activities occurring during the investigative stage are exempt under Government Code Section 7923.600. After that 16 months, this complaint was closed, but then reopened after additional information was received. After briefly being assigned to an HQI investigator again, the complaint was referred and accepted by the AG in the matter of filing an accusation. Over the course of the approximately next 5.5 years, the Office of the Attorney General worked with the Office of Administrative Hearings until a decision was accepted revoking the respondent's license. We selected this sample to clearly illustrate that why the complaint tracking system will show if a complaint is open or closed, and the history of the activities leading up to the certain stages will always be available. There are still processes where there will be infrequent updates available to the user, just by nature of how these activities occur. During these periods of infrequent updates for the user, we want the complaint tracking system to be a tool they can use to confirm if the complaint is still open, if in doubt, and to check to see if any updates have been made as frequently and whenever is convenient for them. Form to contact the currently assigned staff or unit is also available to send a message if needed. So in terms of the next steps to get this proposal to be an actual project, today we will request and hopefully obtain the board's approval of the functionality presented today for the minimum viable product requirements. This approval will allow us to turn this functionality into detailed system requirements and then list the board members that the project sponsor on the Stage 1 business analysis plan required by the California Department of Consumer Affairs and California Department of Technology for their approval and to determine the amount of oversight needed. Upon approval of that Stage 1 business analysis plan, then the project can officially begin. With the complexity of testing and so many different complaint variations, we're expecting that testing phase to take much time as actual development. Assuming there are no additional resources that are needed to handle oversight requirements or anything else unexpected, we think this is a reasonable timeline for getting that release MVP out into production. We know there's some requests from the interested parties and some things that we'd planned from the first proposal that we're electing to keep out of the minimum viable project just to reduce the complexity. So after the minimum viable product release is completed, we can turn our attention to those enhancements and add more functionality to the system. The first enhancement is to send automatic email notifications, which is something we're actually planning on working on concurrently with the complaint tracking system development, as those automatic email notifications will be achieved using an interface that is developed by the Department of Consumer Affairs for sending emails based on triggers in Breeze. So it is effectively not part of the complaint tracking system. Breeze would be able to send those triggers once configured the way we'd like them to work. To view electronic Copies of the original paper complaint forms and the copies of letters will require web services to pull files from Breeze, which currently do not exist. We have to work in coordination with the Department of Consumer Affairs to develop those services, and the added complexity of trying to do that during the MVP release would mean more risk and a longer development timeframe. Logging messages and uploading files into Breeze would require services that can insert data directly into Breeze, which is another set of web services that would need to be developed. Keeping these items as post-MVP enhancements minimizes the risk for the MVP development because read-only web services to pull complaint data from Breeze is something we're already familiar with. I'd like to thank Nicole for being here with me today and all our hard work on this proposal to date and assistance with conducting interested party meetings. We're happy to answer any questions you may have. Otherwise, I have a formal motion request if you're ready for it.
Thank you.
Ready for it.
May I have a motion to approve staff's proposed minimal viable product functionality for preparation and submission of a stage 1 business analysis as required by the statewide Information Management Manual, Section 19, project approval of lifestyle to pursue development of the online complaint tracking system. Will the
So
member
moved.
make a requested motion?
So moved.
Is there a
Second.
second? I want to thank Dr. Balat, Ms. Lubiana and the stakeholders and the board staff for this. I wonder if I might ask Dr. Balat and Ms. Lubiana whether you have any initial comments before we open up to the members. You don't have to, but give the opportunity if you like.
Oh,
Lubiana?
Thank you. Comment and a little bit of feedback, but thank you for all of your work on this. As we've talked about, it's great progress and it's progress that should be celebrated. One feedback that I had, and I love how it's set out with the colors and everything. So just some small things. The number where, like, for example, we say 11 items out there. I'm wondering if we can show, like, break that out more. So if there's, 2 outstanding or something outstanding, like, break that out. And we've also talked about how, I like to serve it up to the customer, make it as easy as possible. And so one thing that I think is important is, if possible, is to use deadlines and dates and numbers to make it more quantifiable. So for example, like in what's shown up here, complaint received, and it's received and entered into the Breeze system. Something that might be helpful is to set an expectation to the complainant, like it will take a minimum 30 days for a response, just to set an expectation, and they're not expecting something a day later. So something like that. Or if there's a request for a document, maybe we add something like, please try to submit this within the next 30 days, or just some number to help drive the process and not leave some unanswered questions. I think if we could do something like that, it would be more helpful.
Yeah, thank you, Ms. Lebiana. We actually have that in progress. We just haven't gotten to the exact definitions. It's something we know that, especially when there is action required on the part of the complainant, that it is helpful for them to understand how long it may or may not take, especially because if you're thinking, look, it's outstanding and I sent it, So it's one of the things that we're trying to get a little further into. And as Sean mentioned, with definitions and further links, we absolutely have already, started discussing with the programs, coming up with possible timeframes, either required by law or just business process. So that's absolutely something we looked into. But
Great.
to your point about number of complaint activities, it's possible that, as you see on this one, that there could be some open complaint activities that the complainant could or could not affect. For instance, if the records are requested from the subject of the complaint, it means that we've already received a release from the patient. So in some cases, it might just be that the subject works for a smaller practice, and so they maybe can't get them right away or something like that. And so I like the idea of number of outstanding, but would you be okay with us saying number of outstanding items that a complainant could affect versus,
yes, absolutely.
so that they're not like, well, it is outstanding, but I can't do anything about it, kind of. Is
That's
that okay?
exactly what I
Okay,
meant for
okay, great.
them, so they know.
In, in
Thank you.
the in the yellow, red, and green scheme, we were trying to figure out some other color, some other way to say that this is something you can do something about
Yes,
versus
exactly.
this is something else just pending. And so instead of a color, we were thinking like an icon or something like that. It's definitely something we can incorporate in there and do
Thank
that
you.
there. And we did intentionally kind of shy away of putting any dates or all the descriptions in here are just samples of, rough cuts. I mean, we spend a lot of time working on this, don't get me wrong, but we until we have that formal project and actually can build some of those formal requirement documents, we won't be picking and choosing every word exactly yet. And then the idea would be that we can put that information into the system, launch it, and if in 2 weeks go by, we're still getting questions from somebody asking, how long does it take to get this document? Well, we can on the fly change that, not have to wait for a Breeze release or anything else tied to Breeze to happen in order to translate that description as something else to get that new information out to people right away.
Wonderful. Thank you.
So, hey, I want to emphasize as much as possible. This isn't a final product.
Yes.
This is just my doodlings, basically. So.
Thank you, though. We take your feedback and we'll make a note.
Thank you.
Dr. Blunt.
Thank you very much. I just want to say that this was a very enriching experience. I think that the public comments and the ability for us to communicate really quite openly and with good rigor, I think was very instrumental to arriving where you are for those that have had to launch programs like this. This is not easy stuff, and I think you've done an amazing job. Is it there yet? No, but that's why you're saying we need to do it. You can't do a project and theorize about it. You have to launch it, and then you can get the continued and important public comments and from the board as well. But I think it's a real tremendous step forward. So I just want to thank you both for really leading it and making it come to life here. So thank you very much.
Thank you.
Thank you. Other members? Other members? Okay. Dr. Mahmood, make sure I didn't miss you. Okay.
I'm good.
Comments from,
He's waving.
I just want to make sure I didn't miss you. No comments or yes?
No, I'm good.
Okay. Okay, for those in the room, hearing room, come forward, please.
Thank you again for your work because that's helping us to move forward in what we are trying to do with our organization and the people that we're helping. Now, we wanted to know whether or not when a complaint is closed, unless information is sent, what is the process for that? Is there someplace that shows the person how to send in more information? Then another thing is there was information on the bottom of one of the forms that looked like it was in Latin. And I'm wondering, will there be some translations of things like that? And then I'm feeling that there would be a constant monitoring of email if you don't get any snail mail from the organization. And so is there some way that we would also be able to get a letter along with the fact that it's on email? Because if you open up your email and see 900 people that got in touch with you that day, you're like, you might miss it. Okay. Then in situations like where they're saying it's insufficient evidence, you mentioned that, we're at a point where we're wondering, can there be a citizens review board to some extent? Because consider this, if staff at Planet Fitness know that CPR is contraindicated for a head injury, if somebody falls there, they're not going to give them CPR because that's contraindicated. Why would a doctor in a hospital do that plus give a person epinephrine, So we're trying to figure out, can there be some type of a common sense board other than the technical people? Because once somebody comes down with a decision, but then from what we've seen of other complaints that have gone in, you don't even know what the respondent said to what you complained about. So we need to find out what's really going on, and especially when you have doctors that at one point in the investigation, but then they are not licensed, and then you look around and then all of a sudden they have a license where people are coming to the meeting saying that they've been waiting 3 years to get a license. How did somebody all of a sudden get one? There's some funny stuff that happens along the way. So anyway, enough of me and enough grandmothering for the moment. Thank you.
Thank you very much. Here's a question though, among those 27 suggestions, was there a suggestion about receiving an mail in addition to email?
Yeah, and I skipped over some of that from the original presentation. But again, the complaint tracking system, the proposed idea is that this is to supplement the current paper processes that are currently in place. So none of that changes. This is to hopefully beat those paper processes. You know, like I mentioned, they have to be delivered via postal mail. And then if someone wants to contact their analyst or the assigned unit, they have to call during regular business hours. If they have the direct contact, if they don't, they have to call through the phone tree. And that can be inconvenient, for normal people. And so the complaint tracking system will have, a high availability to the point where it's available after hours, on weekends, things like that, so that people can check that status there, send in requests to be contacted back, the following business day or whatnot.
Yeah, thank you very much. And you said those 27 suggestions are actually on our website. So
The 27 suggestions were posted, yes, with these slides as part of the materials for agenda item 14.
thank you. WebEx?
All right, now I gotta put my headphones back on.
While Sean sets up, I will respond to just kind of the email part of it. Right now, individuals call complaint, analysts and things like that, and we have what it's called an analyst of the day, and that's not really trackable. So we do think that yes, you can still call and you can still write, and there's still many other ways that you can approach a board. But we have discussed, managing that and making sure that they're not sending emails into the abyss, right? So that everybody actually does get a response. And so at least, email wise, it is able to be a little bit more managed and trackable that way. So.
And yeah, it's came up before that people have made requests to contact their analysts and have not been responded to. That they've called into the main lines and not been able to get in contact with people and stuff like that. So we really think this contact form for both the board and for the consumer gives them proof, right? They submit this form, they'll get an email saying that I just submitted this request form, so they have like a receipt of that request, and it's logged into our database, so we can see yes they did do it. Why didn't and we're gonna have a little mechanism in there or something to indicate that request was responded to, whether it be an email or they called back or something like that. But that way we will have a record that the request was made and eventually the request was fulfilled. And so we can keep better stats on that instead of a call directly to someone, a voicemail's left. We don't have any, statistical measurements on anything like that. Whereas through these contact forms we can. So.
Gotcha.
So anyone on the WebEx wishing to make a public comment, you can go ahead and use the hand raising feature or type something in the Q&A box, and we'll call on you in the order that we see you. Also, if you're on a call-in only line, you can press *3 in order to be queued up that way. So first up here, we have Michelle Montserrat Ramos.
Good morning. I am Michelle Montserrat Ramos, and I'm with Consumer Watchdog. We are pleased to see the minimal viable product, or phase 1, of the online complaint tracking system moving forward. This has been a request that we were happy to finally see materialize. We would like to thank former board member, Dr. Yip, for his support in encouraging the board to move forward with this project. We would like to thank Sean and Nicole for their work on this project, Dr. Bolat and board member Lubiano for their participation overseeing the interested parties meetings, Carrie for her participation in the interested parties meetings and her legal overview, and the board for their support of this project. We just have a reminder that we will need to include the required interview and the patient impact statement in the first phase of the online complaint tracking system. We look forward to continuing to work with staff to see that the enhancements and the items that are important to the public will be added to the next phase. Thank you.
Thank you for your public comment. Next up here, we have Rosie Arthur's-daughter. Rosie, you should be receiving that request.
Okay, thank you very much. And I do want to thank you for all the hard work you've done on developing this first phase of this system. And having done this myself back in the 80s and 90s, I know the type of work you have ahead of you. I do have a couple of brief comments. That email form, contact form, it would be very good if you had an ability to include attachments to it. Maybe it might be limited to PDF forms or, JPEG, or, that may be one way to show that you've actually conveyed the evidence. And that's the other thing too, is be able to document the actual evidence that the patient or the complainant is able to provide, because it may be entirely different and will be entirely different than the electronic record that you are going to receive. And so those records oftentimes are partially created by AI as well. So it's something you need to be well aware of when you're collecting your evidence and processing the complaints. Also, when you go into Breeze, it would be good to have some sort of a flag to indicate that there is an extraordinary process in place. So like you have the place in the details screen for records or whatever, you might be able to put something in there to at least put you through to somebody, a gatekeeper or whatever, for that. Because there may be people who are compliance managers who are monitoring people, and they would need to have some way of doing that easily. Also, this is only the patient and authorized representative complaints. There should be some vehicle for the third-party complaints, like the coroners, who should be, giving you evidence when they see something, or it might be other providers in the workplace who are in a place where they see
30 seconds.
Something happening and need to be able to report, and it may not have the patient's approval yet. So, I think that's a process that needs to be considered there. So yeah, that's the quick part of it. Thank you.
Thank you for your public comment. At this time, I'm not seeing any additional requests in queue, but I'd like to respond to that one if I could real quick. Dr. Hawkins, Sorry, too many things going on. So in terms of the file uploading capabilities, that is something that was definitely requested in interested party meetings. It was an original requirement from the May 2022 report to push unsolicited files into Breeze or into any other database is obviously a big security risk, thing like that. So there's that was definitely in our list of the enhancements column. It's kind of the last one because it's one of the more riskier ones, but definitely something that we want to incorporate into this thing. There will be some file size limitations just because we can't have people uploading terabytes of video or anything like that. But we'll definitely work that out when we come to that part. But one of the real important distinctions made from this presentation to from the last presentation to this presentation is that patient or authorized representative thing. I want that to be very clear to all the board members, because that will be documented in the stage 1 business analysis plan. The mechanism for the third party complaints, that's documented in the tracking list is why that's not legally possible at this time. And so it will be, I submit a complaint on behalf of myself or someone who I'm the authorized representative for, I get to access that complaint. Anyone else I want to say is an authorized representative for me, they can access that complaint. But we have to be the people that submitted the complaint, not a third party. And just because that third party submitted a complaint that they weren't technically involved in, yeah, they weren't the patient, they will not have access into that complaint. So it's they'll be able to log in there and see some details. If you have anything to add, go ahead. But you know, something submitted by a coroner, if the coroner is the complainant, you wouldn't have the direct information about that complaint to log into it. Happy to answer any questions you guys might have about it. I know that's kind of.
And we did talk about providing authorized representatives access to the complaint if the complainant does provide that information. However, there would not be any separation of information. So for instance, if Sean, submitted a complaint and he gave me access and put me as an authorized representative, he'd see everything. I would see everything he submitted it. So medical records, when eventually that would be available, medical records, pictures, accounts, things like that. Anything that is available to the complainant is going to be available to any of the authorized representatives that are allowed to be on that complaint as well. So just to be, because we're assuming that you're their attorney or authorized representative and you are available to be involved in their care and get updates on their complaint. So just wanted to also make that extremely clear as well too. So.
Can I just ask a question about that authorized representative? Because how do we determine that now, I guess? I mean, can you appoint an organization to be your authorized representative, or does it have to be an attorney, or is there some, I don't know, I guess that's probably a legal question for Carrie. Since
Carrie can
check
answer
on
first
that.
part. Right. I mean, this would be someone like a parent of a child, a conservator, or an attorney, or someone where they've specifically said, this is the person who's helping me with this process, and you're authorized to share my information with them.
And in the system, we would denote that separately, basically. So that's how we would know.
And that information would be submitted with the complaint or in follow-up with working with the complaint. You don't actually delegate that access to someone through the complaint tracking system, at least not in the first release. You'd actually have to submit a form to your central complaint analyst or something to have that person added to the complaint in Breeze, and then the complaint tracking system could let that person in.
And do we gather that information in our complaint form now, or how do we make that authorization happen?
Sometimes it's through the complaint process. They provide the information, or staff asks for it. Like, what's your connection? We need appropriate documentation because, we deal with such sensitive information.
Right. Okay, thanks.
Sean?
Yes, Mr. Watkins.
Yeah, Sean, so where is all this information going to sit? Is this, will you be aggregating the information of the Breeze database and it sits on a server with the medical board and the security around that?
So there's no aggregation. It's one-to-one complaint. So I log in, I want to see my, this particular complaint number. It's going to reach out to Breeze directly, pull that data out of Breeze, translate it into more consumer-friendly descriptions and things like that, add the colors and the styles and everything like that, and then put it on the page. So there's no secondary storage of the complaint information outside of Breeze.
So Breeze is is the secure space from which we draw the information.
Correct. Yeah.
Perfect.
Breeze
Thank
is
you.
always our database of record for everything. There's to get into the technical details, there's a mirroring of the data in Breeze that goes out to a data warehouse. It's very quick, and it'd be advertised probably that it'd be a 2-hour delay from an analyst typing something in. In reality, it's seconds. So the minute anything gets updated, it'll be reflected in the system, just like if you refreshed a web page, right? Anything new show up there. And so that being said, if someone prints it or anything like that, screenshots it, posts it on social media, emails it to their family or something like that, we can't control what happens to it after that, right? We've authenticated the users, the one who logged in, As the complainant, they got the little one-time code to access the data, and we gave it to them. If they do anything else with it, that's got kind of out of our hands. But there'll be a big disclaimer about being careful with all that, you know.
And just to clarify a little bit more, so what you saw in Sean's examples would be information entered into Breeze by the analyst. So in some you saw, that if a complaint was submitted online, you would see the summary that the complainant submitted. However, we'll determine eventually and we generally kind of, obviously, to be able to do this, to give you something, have an idea of what we would or would not show. So there could be additional information in Breeze that we would not deem appropriate to release out, but the ones that we do, you're seeing that's coming from Breeze. So if the analyst enters it, it's as real data as the analyst entering it. So as soon as they're reviewing things, obviously if we've received a release, but the analyst hasn't had the time to review to ensure we have the appropriate, signatures and things, it wouldn't get updated. But as soon as they're updating Breeze, the complainant will be notified. Hopefully that answers better.
Thank you. Final comments from the board? We have a motion, a second, and we've had discussion. Ms. Moriarty, please perform the roll call vote.
Dr. Bolott?
Yes.
Dr. Healser?
Yes.
Ms. Lawson?
Yes.
Ms. Lubiano?
Yes.
Dr. Mahmood?
Yes.
Dr. Sai?
Yes.
Mr. Watkins?
Yes.
Dr. Hawkins?
Yes. Motion passes. Thank you very much. Item 15, possible action on the selection of 2 members to the Midwifery Advisory Council. Tonya Moriarty. Welcome.
Good afternoon, board members. In April 2023, the Medical Board posted a recruitment announcement on its website for 2 licensed midwife positions and 1 public member position on the Midwifery Advisory Council, MAC. These positions are for a 3-year term that will become effective January 1, 2024, and will expire on June 30, 2027. The applications for the MAC positions are before the board today for consideration and a vote due to the MAC not having a quorum, as the MAC currently only has 3 members. The board received 1 application for the vacant licensed midwife position on the MAC. The applicant is Faith Freeman. The board received 1 application for the vacant public member position on the MAC. The applicant is Tamara Robertson. Both applicants were invited to this meeting. The applicants present today have the opportunity to introduce themselves to the board and to provide a brief statement. Ms. Freeman, would you like to provide a statement?
At this time, Tanya, I'm not seeing Ms. Friedman online.
I spoke with Ms. Freeman earlier, and she was actually attending a birth. She was hoping that she would be able to be online, and she was going to log in, so she may not.
We have Ms. Robertson.
Be
I see Ms.
available.
Robertson online if you'd like to go to her first. And
Sure, that sounds good. Ms. Robertson, would you like to provide a statement?
I just promoted Ms. Robertson. You could activate your video and your audio now if you'd like. We see Ms. Robertson. You're still on mute down there at the bottom.
Hello, everyone.
Thank you. We can hear you.
My name is Tamara Robertson, and I am just speaking to express my strong interest in becoming a member of the Midwifery Advisory Council. As a community doula, I've had the privilege of supporting numerous individuals and families during the transformative journey of childbirth. My background as a healer spiritualist has allowed me to approach childbirth from a holistic and culturally competent perspective. Additionally, my services in the U.S. Navy has instilled in me a deep sense of discipline, leadership, and dedication to a mission. I am excited about the opportunity to contribute to the Midwifery Advisory Council's mission of enhancing midwifery practices, advocating for reproductive justices, and supporting expectant parents. I am confident that my diverse background and dedication to these principles align well with the Council's objectives.
Thank you, Ms. Robertson.
Thank you.
Do we possibly have Ms. Freeman on the phone?
Let me see if I can match any of these phone numbers. I'm sorry. Actually, I believe we do. I can't promote you in the exact same way, but Ms. Friedman, if you're on the line, as I believe you are, you can press *6 to unmute.
Hello, this is Faith. Can you guys hear me now?
We can.
Wonderful. Yes, I am out of birth, so I'll just be brief. I've been a licensed midwife for almost 18 years and have practiced across the U.S. in several states as well as internationally. And I've been here in California now for over 5 years, practicing full-time both as providing home birth as well as opening a birth center in downtown Los Angeles, Mind Body Birth. I have been on state boards in the past, both as the education director for the Oklahoma State Board for several years, as well as part of the Oklahoma team working for licensing and better midwifery care laws for the state of Oklahoma, where I am from. I'm also a founding member and part of the team that organizes the BIPOC and Queer Licensed Midwifery Peer Review Group here in Los Angeles. I'm also a long-term preceptor and have trained numerous midwifery students and residents throughout my career and graduated many practicing midwives today. I would be excited and honored to be a part of the Midwifery Advisory Council, as I know I bring a wide range of experience and expertise regarding midwifery care, especially as it relates to statewide access to care, collaboration of care with obstetrics and hospital birth options, improving outcomes for all birthing people, raising awareness of midwifery care and the benefits and options it provides, including equity in birth health care and the importance of breaking down barriers and improving birth outcomes, especially bias in healthcare towards marginalized communities. Thank you so much for considering my application. I'm grateful for the opportunity to speak with you today.
Thank you, Ms. Freeman. At this time, the board may discuss and choose to approve one or both applicants to serve on the MAC.
Well, thank you both for willing to serve. May I have a motion to appoint Faith Freeman and Tamara Robertson to the MAC?
So moved.
Is there a second? Are there questions or comments from the members? Yes, Dr. Ballant.
If I may, just tremendous work to support women, from the doula to the work that you've done, Ms. Freeman, for educating physicians, residents, and midwives. Thank you for all that you do.
Great. Additional comments or questions from the board? Comments from the room, hearing room? WebEx?
Anyone on the WebEx wishing to make a public comment, you can go ahead and use the hand raising function or type anything in the Q&A window. We'll give everyone a few seconds to queue up if they need to. If you're on a call-in only line, you can press *3 to raise your hand. This time, Dr. Hawkins, I'm not seeing any requests.
Great. Well, thank you very much, Moriarty. So we have a motion and a second regarding the appointment of the Ms. Faith Freeman and Ms. Tamara Robertson to the MAC. Please call the roll.
Dr. Bolat,
Yes.
Dr. Helzer,
Yes.
Miss Lawson, Miss Lubiano,
Yes.
Dr. Mahmood,
Yes.
Dr. Sai,
Yes.
Mr. Watkins, Dr. Hawkins.
Yes. The motion passes.
Thank you, board members, and thank you, applicants.
Moving to agenda item 16, future agenda items. You're aware that we will have a rescheduling of the final report of the enforcement monitor, Mr. Lombardo, hopefully at the next meeting. Do any members have any requests for future agenda items?
Dr. Hawkins?
Yes.
Just one topic that I think would be of interest to all of us at some point in the future, which is, generative artificial intelligence and its potential impact on the medical profession. I think in all the literature we all read, it says, tells us that the medical profession and healthcare generally is potentially going to be the most disrupted industry. And so I think would behoove us all to get ahead of that and at least begin to understand the potential implications. So I don't have a speaker in mind, but I think that the topic, we'd be well served by hearing something about it.
For sure. Thank you very much.
Yeah, I just want to echo that. I know I had raised that at our last board meeting, so I concur with you. This is really mission critical at this time.
Mr. Watkins, then Ms. Lubiana.
I just wanted to have on the agenda the next board meeting suggestions for proposed legislation by board members.
Closer to the microphone.
Suggestions for proposed legislation by board members at the next meeting, so we can make it for the 2024 calendar year.
To appropriately agendize it, we would need to have details about it. So if you have something specific in mind, if you could send it on, because if it gets on the agenda, it has to provide proper notice.
Thank you. Ms. Lubiana.
Thank you. Also, another request for AI, a topic on that topic, and just putting a nudge on my previous request on neurodiversity.
So regarding the AI, the Federation of State Medical Boards actually is going to do a presentation in January 14th in DC, I believe. So check your emails or check the FFC Insight. Additional suggestions, requests, interests. We have a list of others that we need to consider for sure, several from the public. Well, I think, yes, come forward.
We are requesting, I say we because we have an organization, but we are requesting that there be a better monitoring of senior care, because what we're dealing with with a lot of our people that we work with, they end up atrophied because they're doing absolutely nothing and laying in beds. And under those circumstances, there needs to be a requirement of places where seniors are to have some type of athletic equipment for them to work with. And some other things that need to be done along with along with monitoring them for diets, because you can get tired of peanut butter sandwiches, and it's something peculiar about the fact that seniors will be in these situations, and the amount of their income that is taken out for their housing, especially in assisted living, leaves them with between $15 up to about $35 a month. So they can't even go to a concert or anything, because all of their money is being grasped in order for them to be in a space that doesn't even have a gym in it. Okay, that was one thing. Now, with our foster care youth, many of them are not being monitored by the schools and government, and a lot of our kids are ending up in things like prostitution, all kinds of things when they turn 18, based upon the fact that if you turn 18 in April, the foster care person is pushing them out the door. And so here's a bag, plastic bag with your stuff. Not everybody, but it's happening to youth and others. And there's a lot of problems that's going on that need to be taken care of. And especially with the babies being sold to people coming into the United States for $15, and they're being, forgive me, put into very odd situations. And I'm sure you know what I'm talking about. Along with that, we also would like for you to put something down so that you have a DNA service, because it makes no sense that when you go to the coroner because there's a problem with somebody, then they recommend you to people in Massachusetts, Texas, Iowa, Montreal, Paris, and all these kinds of people. Well, the family can do it, but they can't do it. And they're saying they're bound by the fact that the one doctor that was the initial doctor that signed off did not, they couldn't find him to look at the second autopsy. That's crazy. You know, it's kind of like the guy that's the offender is protected because they can't reach him for him to sign off when it showed that the person didn't have COVID or pneumonia and that it looks like organ harvesting. There is something else on here that I probably need to say. Also, let's see, where is it? We basically the need. We have lapses in personnel, so we need to be at the point where you guys can get to the people, but we also want a citizens review board so that if somebody says, okay, your case didn't go, well, let us know what the other people said, that why you are agreeing with the position, because we're not receiving a response as to what was said that was in a disagreement with the complaint that was made. I think that's my time running out. I really appreciate you guys. I mean, it's a haul from LA to get here, but I'm a trucker. And I thank you so much for having these meetings, because it gives us a chance to express things. And but for sure, we definitely need to know if you say no to something and you say that it's a slim case of no, but then let us know why you said no, so that we can see whether or not we have something that goes against what was said by the person who is the possible culprit.
Thank you. Now, you mentioned two very vulnerable populations, seniors and those in foster care. I would just ask you to narrow your request for future items and put it in writing.
Okay.
Thank you.
So now who should I send it to and how should I send it for the request?
You can send it to webmaster@mbc for Medical Board of California .ca.gov. And
should I put to
identify it,
anybody's attention?
just identify it as a future agenda item request.
Agenda item. I really do appreciate you guys.
Thank you very much.
God bless everyone.
WebEx?
Anyone on the WebEx wishing to make a public comment, you can do so by raising your hand or typing anything in the Q&A window. First up here, we have Rosie Arthurstutter. Rosie, you should be receiving that request.
Hi. Yes, I want to address two things. One is I definitely agree you need to address AI, but also, again, coming from an area where I've worked with database and information management for decades, and AI has been in place for a long time. You just didn't know it. Even before the electronic medical records, there was AI going on. So there's no getting ahead of it, which means that you have to make a deliberate look backwards to see where and how it has invaded your process. And there are clear problems that you already have now, and that would be why some of your complaints have gone off the rails. Okay, so definitely they need to be looked at. The other thing is the item with the coroners not making what are essentially mandated reports. I would expect there to be a smattering of them, but for there to be none in the last year, and how long since this has been in effect, since 2013, what is the history? So that's an issue that we need to look at to see why this isn't happening. Is it a policy or advice somebody is getting? Right now, the Coroners Association here in California is actually having a convention in San Francisco. So they're not available to next week, but I am going to contact them about that, and I'll get back with you with more of a formal agenda item for it, because there's got to be a reason why there's no reports, when clearly with all the problems related to controlled substances, COVID, any number of things that have happened that we know is happening, and to have no coroners making any reports, and having dealt with a coroner that says we don't test this, when the previous presenter mentioned that they don't do certain tests. In Contra Costa, they have a whole floor that's a lab that they don't use. You know, the basic tests that they should be doing, they are not doing them. So there's something that is keeping coroners from
30 seconds
actually
remaining.
doing the job that we expect that they should have been doing all along, and that whatever comes from that. So I think there may be some interference that's keeping them from doing it for some reason other than following the law in good faith. Thank you.
Thank you for your public comment. And next up here we have Michelle Montserrat Ramos. Michelle, you should be receiving that prompt.
Good afternoon. I'm Michelle Montserrat Ramos, and I'm with Consumer Watchdog. We are requesting an update on the maternal mortality maternal health report. We're also requesting a presentation on the effectiveness of the uniform standards, how often the standards are used, which standard is most violated, how often is the cease practice order used, and how often the board is complying with uniform standards or deviating from the standards. And also a presentation on 805 reporting and bringing the Department of Public Health Licensing and Certification Program representatives to a board meeting to discuss how the department can work with the board to share hospital disciplinary actions with the board and other enforcement actions information that the board is not receiving that will benefit the enforcement program. In addition, I'd like to take a moment. We would like to congratulate Dr. Hawkins on his appointment as president of the board and Ms. Lubiano and Mr. Brooks for their leadership appointments. We look forward to continuing to work with you on issues important to the public. Thank you.
Thank you for your public comment. At this time, Dr. Hawkins, I'm not seeing any additional requests in queue.
Great. So I want to thank everybody for their participation in this mid-board quarterly meeting. And our next agenda item is 17, adjournment. Safe travels.